It is 8:07. Good morning. My name is Linda Kopecki, and I'm the Interim Executive Director of the Minnesota Breastfeeding Coalition. I welcome you to our 2020 Perinatal Hospital Leadership Summit. This was a long time in coming. We started planning just almost a year ago, thinking we were going to have an in-person summit in May. That quickly got derailed with the COVID-19 pandemic, and many thanks to our amazing planning team with the Minnesota Breastfeeding Coalition. We had many long discussions about the summit and other offerings that we routinely do each year, and we quickly pivoted to this virtual version. So thank you for being patient with us while we pivoted. And thank you for joining us. This is an exciting day. I want to just go through a couple things. My summit co-chair is Dr. Pam Heggie, who is a pediatrician and a board-certified lactation consultant and an amazing partner with the Minnesota Breastfeeding Coalition. I'm just going to go through a few housekeeping details, and then I'm going to have Pam run through the agenda really quickly and present our first keynote, who we may have to shuffle the deck a little bit because he has not joined yet, so we'll see. I want to just take a moment, please, first, and I'm going to just recognize where we are. The Minnesota Breastfeeding Coalition acknowledges that we are holding this virtual workshop on the traditional, ancestral, and present-day home of Indigenous communities. The beautiful land we all love is the stolen land of the Dakota and Ojibwe. Today there are 7 Ojibwe reservations and 4 Dakota tribal communities in Minnesota. For the majority of the thousands of years Native Americans and Native families have lived on this land, babies thrived on their mother's milk. Colonization, violence, and forced family separation destroyed the legacy of breastfeeding within these communities. Minnesota Breastfeeding Coalition is honored and privileged to work alongside the Indigenous Breastfeeding Coalition of Minnesota, as well as many Indigenous and non-Indigenous lactation professionals and advocates to reclaim breastfeeding as food sovereignty. 2020 has been a period of collective reckoning of the structural racism inherent in all of our systems and communities. May we work together for justice and reclaim breast and chest feeding as the norm. Before I hand this over to Dr. Heggie, I just want to mention that the evaluations that are linked to your continuing education units, those evaluations will be sent to you after the workshop tomorrow. So we'll send it to you through where you registered, through the registration portal. We'll be sending that out, the evaluation link. So you'll do an evaluation online, and then you will receive your certificate. So I'm going to, and then if you want to ask questions, please use the Q&A function. This is Zoom webinar, and we have chat, but we also have Q&A function. So please use the Q&A function for asking questions. And we'll have question and answer at the end of each presentation. We'll have 5 minutes at the end of each presentation. And so please fill the Q&A with your questions, and then we'll go through those. So I'm going to hand this over to Pam Heggie.
Hello, everyone. Welcome to our 7th Perinatal Hospital Leadership Summit. It's very exciting to have you all together, even though we're not all in person. I look forward to other years where we can be in person and network with one another. We have an exciting lineup of speakers today and tomorrow. Here's the agenda for today's event. And as we've done for other perinatal summits, we always invite national speakers to present to us about our topic. And we also invite local community speakers, people from throughout Minnesota, to share what they're doing at their sites so we can all learn from one another. And again, we don't have the same networking that we do when we're in person on this virtual platform, but I think we're going to try to make it as collaborative as possible as we go through these 2 mornings. So the agenda for today is up on the screen, and we're going to go from 8 until noon. We'll have a 10-minute break in the middle, and then the question and answers, like Linda talked about. And I'm planning to introduce our first speaker, and I need to ask Linda, is Dr. Kim on the line now?
I don't see him quite yet, but what I suggest we do is we have a couple videotape provider stories that are really
good idea
in sort of setting the tone. And what I'd like to do is start our day off with showing one of those recorded provider stories, and then we can hopefully pivot back and find Dr. Kim. So Pam, I'm going
Sounds good.
To see if you can reach out to him and see.
Yeah, I'll see what I can do.
So the first provider story that I would like to present is from Nora Flood. She is a new OBGYN and also a breastfeeding mom. So I'm going to quickly share her video with us. Just a moment. Just take me a second. Sorry about that. You may have to turn your audio up.
Hello, my name is Nora Flood. I am mother to Marie, a beautiful and busy 20-month-old toddler. I am also an obstetrician gynecologist. Marie was born just 4 months before I finished my residency training. For me, I never had to choose breastfeeding. I just knew I would. I knew it would keep Marie safe, healthy, and above all, maintain the intense connection we formed during my pregnancy. We joke that with all our support and luck, we should have several kids by now. My pregnancy was healthy and physically easy. Marie was born after a short, easy labor, and we never had to be separated. In fact, one of my co-residents delivered her. My dad retired a few months before Marie was born and gamely volunteered to provide full-time childcare after my maternity leave and my husband's paternity leave. And as some of you may know, my mother is a lactation consultant with dozens of years of experience helping mothers and mentoring other breastfeeding counselors. She was as invaluable as a cheerleader as a practical resource. In addition, I was fortunate to almost always encounter supportive colleagues and supervisors. True, I had to store some of my oversupply in emptied out sterile saline bottles next to questionable leftovers in the common fridge, awkwardly ask for more time to step away from rounding, and pump in shared workrooms near strangers from time to time. But as all of us residents who had babies expected that sort of thing, I shrugged and just went on taking care of my baby by pumping and breastfeeding. I had the advantage of being a senior or fourth-year resident with more agency and discretion in deciding how to spend my time. In fact, my junior resident was actually an experienced mother herself and was more than sympathetic to my need to pump frequently and cry on occasion. But since I was healthy and well, I returned to the hospital for a 28-hour call shift just 6 weeks after Marie was born. I remember crying as I entered the OR to scrub out the prior shift that was finishing a C-section. To be away from her for so long, my heart broke. I remember the terror the first time I went more than 4 hours without pumping. Would I lose my supply? I remember the shame when she started preferring a bottle to latching, despite my dad's attempts at paste bottle feeding. Eventually, she learned to like nursing again, but it took a long time. So, what's the biggest barrier to getting other OBGYNs to support breastfeeding? In my opinion, we're not very good at seeing it as tied in with rather than opposed to other priorities. In a high-risk pregnancy or delivery, we breathe a sigh of relief when we can keep mom and baby alive. Beyond that, our job feels done. Even when we're educated about the health and bonding benefits of breastfeeding for mother and baby, it all seems minor compared to hemorrhage, high blood pressure, surgical complications, or whatever other emergency might come our way. The second factor is time. Whether imagined or real, OBGYNs seem to rush through everything. I'm not sure that this is going to change very easily. Our culture and profession dictate that we need to respond to emergencies at the drop of a hat. It seems like there are always competing responsibilities to the patient in front of me, my pager, clinical decisions I need to consider for tomorrow's clinic, postpartum rounding, educating residents, not to mention my own family. Even now, out of residency, it's not uncommon for me to clock more than 80 hours in a work week. Overall, it's much, much less than residency, though. Sure, I could have demanded more than 6 weeks of maternity leave, but I would have had to extend training, and what's worse, place even more of a burden on my co-residents. Without intending to do so, we seem to develop an attitude of, well, since I did it, you can too. Just suck it up. Take the 6 weeks, no more. Pump every 5 hours or every 6 hours. Not all of my colleagues had it so easy. I've heard stories of staff doctors belittling residents for taking time away to pump, and the quiet shame of residents who had medically complicated pregnancies and had to take more than the 6 weeks allowed by the program. When a single resident is gone in a stretched-thin program, everyone else has to bear the burden. It's a system that sets us up for rancor and bitterness, which we easily pass on to each other and our patients. That's how culture is created. Breastfeeding also changed how I approached patients. Before having Marie, for example, I never even thought to ask a mother readmitted to the hospital postpartum if she was breastfeeding. Weeks after she was born, I saw a patient in the emergency department for an infected cesarean section wound. Her newborn was in the car seat across the emergency room, and my patient was stuck in the gurney, in pain, unable to get up and reach her baby, with milk soaking the front of her gown. It was so easy to ask her permission, bring her her baby, and then set them up with a pile of pillows so she could nurse while her evaluation was completed. But would I've even noticed that before having Marie? I've also learned to subtly check in with the trainees I supervise. So, do you have any kids? How old? Are you nursing? Do you need to pump? I've also learned how amazing hospital lactation consultants can be, lending hospital-grade pumps or even filching some parts for me, but more professionally, also troubleshooting patients' problems together, combining their wisdom and experience with my medical savvy. That way, when I'm postpartum rounding and truly am in a hurry to get to the next thing, I can genuinely say, oh, I'll be sure to ask so-and-so, the lactation lady, to come see you. She's great. In summary, I think that supporting trainees in breastfeeding ties in profoundly with supporting our patients' breastfeeding. It's shameful that anyone in our country must accept as little as 6 weeks of maternity leave, but I know that even that would be a dream for many women who go back to work after a couple of weeks or a few days. Supporting all residents, whether parents or not, with less demanding schedules and filling the gaps in coverage would go a long way as a foundation. Simply asking, checking in, and being open about our own experiences with breastfeeding and parenting seems to help as well. And if we really are busy running to the next emergency, we should know how to turn to who has far more expert advice than ourselves. My daughter Maria is still nursing, by the way, and we both love every minute of it.
Hello. Is it time to introduce Dr. Kim?
Absolutely. Thank you. So
Okay.
thank you for
Welcome, Dr. Kim.
working with us to adjust a little bit.
Yes, well, it's my pleasure to introduce our first speaker of the day, Dr. Jay Kim, who is professor and director of the Division of Neonatology at Cincinnati Children's in Cincinnati, Ohio. He recently moved to Cincinnati from San Diego, where he practiced neonatology and helped to establish the San Diego Mother's Milk Bank. He did his medical school and residency in Toronto, Canada, and in Toronto was also involved in establishing the Toronto Mother's Milk Bank. Dr. Kim is a pioneer in human milk science, and he's published numerous articles about human milk and premature infant nutrition. Please welcome Dr. Jae Kim, who will speak today about why human milk matters and its impact on infant mortality. Thanks, Dr. Kim, and welcome.
Thank you. Let me just get my slides up, if I could. Let me know if you see the slides okay.
It's absolutely perfect. Thank you. Welcome.
All right. Well, thanks for the invitation, and hope to give you a perspective of how we see mother's milk as being critical in a number of different contexts and what potentially the future may hold. These are my disclosures, none of which that should impact this talk. So a huge driver is for us to move away from animal sourced milk. And this is in recognition really across the world that human milk is beyond just a nutritional, and really recognizing it similar to how we look at blood as being a liquid tissue. And we know that because there are characteristics that are similar in terms of cellular content and biologically active compounds that are there in addition to the nutrient requirements. And so we have seen some tremendous trends over time that have been beneficial in terms of humanizing the diet that we see for babies. And so a drop over a period of time in terms of formula, in particular preterm formula, with an increase in all sorts of mother's milk and mother's milk derivatives that have increased. These include more of mother's milk, more donor milk, more of derivatives like fortifiers, or even cream that's skimmed off of donor milk, etc. And so the more we get into mother's milk, whether it's in the NICU or in the community, the more we have to understand deeper exactly how this compound actually, this liquid actually works. So it's important to separate out the cellular components into human and microbial. We now recognize that mother's milk has wonderful immune cells that really provide cellular protection. But we also know, because they're human cells, that when we handle the milk, in particular when we freeze, that these human cells will lyse and no longer be functional. Also, when you move milk from container to container, many of these cells get lost because they tend to have adherence properties, and they may stick to containers or surfaces and get lost after multiple transfers. The other component that's cellular are microbial. And remember that bacteria have cell walls. And when they have cell walls, they're more sort of impervious to freezing effects, but they're not impervious to heating effects. And we'll get to that when we talk about donor milk. And we often overlook the nutritional components of human milk in the sense that, oh, protein is sort of amino acid is an amino acid, or protein structure is similar between animals. Same with carbohydrates or even lipids. But you can go deep into each of these macronutrients and discover that there are very specific characteristics of these molecules. So, for instance, very specific human type proteins that lead to not only differences between the casein and the whey, but even their actual protein structures that are unique, that cannot be completely replaced by animal-based protein. And probably the largest explosion is our understanding about carbohydrates, because the lactose, which is the predominant carbohydrate in human milk, is similar in structure to any other lactose, because it's a fairly basic disaccharide. However, there's a very large component in the carbohydrate group called oligosaccharides. And these represent a genetically modifiable group of sugars that are really the essential prebiotics that are present in mother's milk, and are unique in humans and unique in quantity. For whatever reason, humans have the most amount of these human milk oligosaccharides, or HMOs. And so that makes this group very unique. And if we look at lipids, same story goes, that fat is not the same as any fat, that when you dive deep into the actual chemical structures, you end up with some very unique characteristics of the triglycerides, the actual fatty acid chains. And these differences are very different than what we find in formula, and formula derives most of their lipids from plant-based sources. So we're really kind of comparing animals with plants when we're looking at that component. But probably the most surprising and most complex aspect of human milk is the multiple components that are present that we sort of call biologically active. And they're biologically active in many unique ways. And I think it's really a feat of nature that we see such complexity, whether it's antimicrobial function, anti-inflammatory function. I think the presence of hormones and growth factors are really all adding up to some interesting stories of how important mother's milk in modifying the gut health and the whole body health of babies. We won't talk much about digestive enzymes, but I think when we talk about donor milk, we'll see that unique to mother's milk are digestive enzymes that actually get activated in beyond the stomach, and that are bile acid stimulated, that actually end up allowing for the digestion of itself. So sort of an autodigestive feature of mother's milk, which I think is very, very interesting. And then we look at comparison then when we really put it up against each other, mother's milk against infant formula. You can see why there's such stark differences in property and in why we see such different effects in outcomes. That when we're looking at what was the intent of infant formula, it was really to try to mimic the nutritional profile of mother's milk. And this misses out on all those components, the cellular components, the probiotic components, and the biologically active components that are found in mother's milk. So a really stark difference. And it's important to make that reference when we're looking at mother's milk, because a lot of times people just jump to milk as a nutritional. For the most vulnerable infant, we can take the model of the preterm infant and see that every system of their body is affected in one way, shape, or form because of their immaturity. And this leads to risk for a lot of morbidities. So we have a challenge when we have the smallest kids who now, unfortunately, can be as small as the size of my hand in trying to get them to adapt to the real world if they've come out too early. And we can see in this diagram of developmental milestones that although we get structure early, so something looks like a stomach, looks like intestine, many of the functional aspects of that gut are really either just beginning or haven't started at all when we get babies coming out at such early premature stages. Even now, we're almost at the halfway point of the full gestation. So really significant immaturity. And so that immaturity leads to significant effects specific to the gut. And probably the big things to take home are the immature gut and systemic immune system. That's it's the largest immune system of the body, and part of that leads to a dysmotility, but it's the general nervous system that's immature. And that dysmotility really sets up the gut for a lot of different complications. The overall physical barrier is limited, and we now know that acid production is really important. And the end result is a abnormal bacterial colonization, which we will call dysbiosis, and we'll get into that later. So that dysbiosis is really the setup. So when we look at this high-risk population, we do recognize that mother's milk has significant benefits for the healthy term mother, and I won't go over that in great detail, but I will highlight that we know that mother's milk has benefits in areas that are often not talked about, and that's infant mortality, reduction in SIDS deaths, and we know that that's not as frequent, so it's often not as visible in terms of the casualties that occur, but many other conditions that are either infection related or inflammation related. And then when we look at the preterm infant, we recognize that there's great benefit on a number of fronts. One big one is the impact on cognitive development, but the other big major effect is on a disease called necrotizing enterocolitis. And I'm going to use that as a model to kind of explain why mother's milk is so powerful in this vulnerable population. But we also have other effects with respect to overall sepsis, and in particular, demonstration of changes in the microbiome, and now some data around retinopathy of prematurity, and even some related to chronic lung disease. So I want to talk a little bit about infant mortality, because I think we kind of jump past infant mortality when we talk about the developed world and mother's milk, that the benefit of breastfeeding leads to reduction in inflammation and some of the infection that babies and early infants and toddlers may face. And so that's probably gets most of the press. But we have known for a long time that in developing worlds that there's a significant impact on infant mortality. So I think I wanted to spend a little bit of time kind of going over this. And in particular, taking a look at the more recent reviews to look at different age groups and the impact that mother's milk has on infant mortality, and recognizing that regardless if we look at the early infant period between 0 and 5 months, or a later period where they're in the sort of the toddler phase up until 2 years, that we see that the impact of breastfeeding has on all-cause mortality and infection-related mortality in both groups. And then the other aspect that I think is critical is that even the timing of that initial breastfeeding, so even if they ultimately get access to breastfeeding, that those babies that are exposed as early as possible, getting that earliest inoculum of mother's milk, seems to be protective. So if you separate out those that are less than an hour versus those that get breastfeeding between the second half, beyond the first hour, or even beyond the first day, that the impact of the timing of breastfeeding seems to be very powerful in terms of affecting neonatal morbidity and mortality particularly. So why does that occur? Well, we think that in mother's milk, we have some special ingredients that may have effects on the immune system, and may also have effects on promoting the right kind of bacteria to start to form, because the gut isn't primed yet when they come out. And so being able to stimulate the right kind of flora, the microbiota, that might be one way to protect them against significant diarrheal disease or sepsis, bacteremia. But in the developed world, we don't always talk about breastfeeding leading to reduction in mortality. Julie Ware and others in our group had published data that looked retrospectively across a group in Tennessee, and looked at live births and looked at breastfeeding rates, and showed that even in a developed nation, we can document the impact of breastfeeding and infant mortality. And that we need to kind of go beyond and perhaps do more calculation or studies in this area to look at the impact that is present across a population. And because the numbers can be hard to see visibly, and the correlation may not be so direct, this is where the epidemiologic approach would be important. But I think it's important for us as human milk advocates to be able to take these types of data and represent it, not just as protection against death in developing worlds, but really also here in our own nation. And I look at the body as having surfaces that are exposed not only externally, so you've got the skin, but internally, where you really have surfaces that are barriers that are protecting our body. So they are surfaces like the lung and the GI tract. All those areas are potentially areas that could be affected by what a baby feeds on. And so necrotizing enterocolitis is one of the big nemesis for us in the NICU. We don't like this disease. It has caused a significant amount of morbidity and mortality, but it's not completely going away all too quickly. And we recognize that if we have an approach to prevent it, that's probably the best strategy that we have. And so we've been able to have some impact when we've addressed standardizing the way we feed the gut, standardizing the provision of human milk, and then also what's more recently coming into play is the use of probiotics. So these are probiotics in addition to what's in mother's milk. And we recognize that how we get to this horrible situation of NEC involves the collision of having a premature gut, having the wrong bacteria and the wrong kind of feeding. And what that does in some cases, it leads to rampant unregulated inflammation and then destruction of the wall of the bowel, such that we lead to either scattered or sometimes continuous pieces of bowel that get affected. And if we look at the defense mechanism of the gut, we can see that there are multiple systems at play, but in the immature gut, all of these systems are in some way, shape, or form attenuated. So everything from the mucus layer being thinner to the tight junctions between the enterocytes being more leaky, to the immune system being less mature. And then we talked about the dysmotility, that the gut does not move as easily. All these things play into susceptibility to developing NEC. And so interestingly, the use of mother's milk seems to be acting like a drug, that the more milk a preterm baby feeds on, the less chance that baby has of developing NEC. So this dose-dependent effect is really powerful. And the overall statistics, if we take the highest risk babies and represent them as 10% being at risk for NEC, and then of those that get NEC, maybe 30 to 50% need surgery, and of those that get surgery, almost half of them die. And so we have an intervention we call human milk or mother's milk. We say that we could if we use this, we would reduce death and definitely reduce some of the morbidity with NEC significantly. And the reality is that even after over a decade of many of us advocating for the use of mother's milk in the right way and some of the mother's milk derivatives, we're still seeing many preterm babies in this country being fed formula. Sometimes they don't get fed right away, but there's still many practices that I see that where we're exposing them to formula, and it's still remains a huge problem. So why is that why does that seem to occur? Well, one of the challenges it relates to lactation, that the moms who are delivering early, they tend to have significant trouble with lactogenesis, and we know that there's multiple reasons, whether it's maternal health, the stress of the circumstances of having a preterm birth, but as a group, they are significantly lower in production of milk relative to their term counterparts. So we've got a challenge. And then part of and we're now kind of even understanding how early are we supposed to be able to pump to be able to produce maximum amount of milk. And this is probably could have been updated, but there was some data that suggested that one had to pump very early within the first few hours to really attain success. And now we know with more recent data that certainly within the first 12 hours, having access to pump or manual expression to be able to produce early amounts of milk will be really the setup for that mom to be able to produce the most possible. I put this slide in that societally we kind of have differences in priority. So we finally have a airport that has a lactation room that's available, but alongside it, you can see that yoga is just as important. And this is in California, so they may be a little bit more progressive in that way. But I do think that societally we have some barriers, and having moved from California to Ohio, I think there's more challenges that I see societally in terms of interpreting and promoting breastfeeding. a lot of moms that I've seen so far have already decided not to breastfeed for a number of different reasons. So, so what's the challenge then? Moms have challenges making milk, and if they have a preterm baby, they're even more at risk. And so, if we think that mother's milk is best, then we need to have some mechanism if mom's milk is not available, and that's where pasteurized donor milk really represents the next wave. Are we going to get to a place where we can, by research means, be able to support the artificial manufacturing of human milk? I think we are getting closer, but still far from that reality. People have started three-dimensional culture of mammary gland tissue, largely for research for breast cancer, but there are some means to make milk, a mammary gland in a dish, but they lose a lot of their identity, and you almost have to kind of re-instruct those cells to make milk. So the long and short, I don't think we see anything in the early horizon that is going to save us, and that's why we have really such strong dependence on an industry that almost got decimated in the 80s when HIV came, to now around donor milk use. So we have a long history, but what we've seen, and this map keeps getting keeps flourishing, is the derivation of new milk banks that are populating pretty much the whole region around the US, such that there really shouldn't be a state that does not get served by one or more milk banks that are present. And so, I was fortunate to help the discussion of milk banks in Toronto, and then I left, and took about 7 years after that for that milk bank to form. And then I recently left San Diego, and about a half a year after that milk bank formed. So I'm a little bit tepid about starting anything in Cincinnati, because it seems like every time I activate a bank, I end up leaving. So, but these have been success stories, and I know in Minneapolis too that has been successful to get on the map. But the major driver of donor milk banking is the preterm population. But I will argue that maybe that's not the only target ultimately. So when we think about donor milk, it's great to make sure that not only do we recognize the benefits, in other words, the human specificity, the fact that we can gap bridge moms that are not making their own milk, that we have biologic factors that, although attenuated by heat and freezing, there's still many elements that are there, and that it's very safe, and it's got a very safe track record. We recognize, whether it's a pro or con, the fact that there are pooled components between mothers. And so depending on which component you're looking at, that may be a pro or a con. On the negative side, I think we have to recognize that donor milk is not as profoundly beneficial in terms of all its components because of its handling and heat processing. So we lose cellular components, we lose some of the biologic activity. The nature of the donor milk being later in lactation for most moms donating means that protein in general is lower. And then I mentioned already that heat processing will destroy the lipase activity, which we know that lipase activity is a helpful thing for digestion. So there may be less energy salvage from a donor milk. And we can see that sometimes with babies not growing as well. And then some changes in salts and vitamins that may be important. And then that lack of mother-infant specificity, which I mentioned before about pooled milk, you lose that characteristic. It's not that infant's mom's milk. And to what end is that beneficial to have, for instance, the immunoglobulins that mom experiences in her environment, which is really very close to what the infant has as an environment. And there are a number of concerns that have been raised with donor milk, and I think the industry has really addressed a lot of these. So the nutritional issues, loss of bioactivity, the infectious risks, risks for tampering, and these other practical considerations. So for the most part, we're confident that producing donor milk is still advantageous for the health outcomes of our babies. But if I were to place a kind of a triage of the and rate the quality of the milk, clearly the breastfeeding is at the top, and then every time you do something to the milk, whether you refrigerate it or you freeze it or you pasteurize it, as in donor human milk, you affect the quality of that milk. I think it's important for all of us to now know what the general sequence is when donor milk is being made, because it helps understand what kind of processing takes place and what do you end up at the end of the day in terms of the milk. So the concept of having very good screening and clearing of the vetting of the mothers at the front end, and then being able to take the milk and in a very controlled fashion freeze it, store it, pool it, and thaw it, and then actually pasteurize it. And throughout that process, really do sort of manufacturing level quality checks to make sure that the product at the end is very consumable for even the most vulnerable babies. So a typical bank has many safety measures in place to end up with the bottled product that gets to babies. And even the commercial market, it takes it up several notches higher when they have to use such high volume milk in their ability to process the milk. So we are, I think, both in Canada and the US, we've recognized that the use of pasteurized donor milk is really something that is a safe and suitable alternative. But both communities recognize that the sort of this informal milk sharing that occurs is something that needs to be probably kind of deterred because of the challenges in the contamination risk and the lack of pasteurization that really alters the ability to control the milk from a safety perspective. So I mentioned that I spent some time helping the San Diego develop probably the first university-based milk bank there, and really required a significant amount of effort and the benefit of of having a private donor who was able to support our business plan for this. I wanted to just highlight really the biggest evidence that we have of donor milk in terms of preterm babies, and that's the Domino trial that Debbie O'Connor in Canada from Toronto put out. And really, this study demonstrated in a randomized way, those that got donor milk versus preterm formula, that their primary objective was looking at neurodevelopment and really did not see a difference. But when we looked deep at their incidence of necrotizing enterocolitis, it was clear that those who received donor milk had less incidence of NEC, and in particular, the stage 2 or more, which is more the severe form of necrotizing enterocolitis. So we have a lot of pressure to favor mother's own milk, but we knew, so the obvious question was, why didn't we use it all along in history? And the reason is that preterm babies are a different beast compared to a term baby. They have such high energy and nutrient needs that if you gave them, and these experiments were done where they were only fed human milk, and a preterm baby would not grow well. They were demonstrated to have poor growth, poor bone development, poor brain development. I mean, it was very significant impact because the nutrients that they need are far in excess of what mother's milk can provide. So knowing this, then that's what really led to initially the use of preterm formula as a solution to try to come up with a cocktail that could provide more energy, provide more nutrients. And then we realized that was missing all those biologically active factors. And so for the last little while, we've been really pushing to have at least the base component of diet be human milk based or mother's milk based. And for the longest time, we've been adding a fortifier on top of that in order to make up for the energy and the nutrient needs. And what we've seen in the industry so far has been a change from not just intact bovine fortifiers, but a move away from powdered form to ones where the protein gets chopped up or hydrolyzed. And then for now, it's probably more than a decade of use of human milk derived fortifiers. So they're fortifiers of human milk that are coming from donor milk, and so that the entire diet ends up being human. And so, you know, we were involved in the original study to look at a human milk-based diet, and this study demonstrated that those babies that got the exclusive human milk diet really ended up with a significant reduction in all cases of neck, but in particular the nasty kind of neck, the surgical neck, and that was reduced. And then this impacted the length of parenteral nutrition use, that in favor of those that got the human milk diet. And then when we looked at mortality, clearly the use of even the bovine products that are just on top of mother's milk seem to have an impact on necrotizing enterocolitis and even mortality because of the severity of what NEC can do. So subsequent studies looked at the sort of the cost benefit, and it's very easy to demonstrate that when you have a really significant number of kids who have medical and surgical NEC, these add a long-term cost to their, even if you calculate just the first 3 years of life, significant impact on the healthcare system. And then extension with more retrospective studies looking at a human milk diet across a number of preterm babies and in a number of centers showed that not only were their demonstration of lower incidence of NEC, but also reduced mortality, reduced late onset sepsis, and then retinopathy of prematurity and BPD. And then one of the controversies that I think is adding to the literature is Debbie O'Connor also did another follow-up study that mimicked the Sullivan trial that I just showed you around using the human milk, the fortifier of human milk that's human milk based. And in that scenario, they did a smaller study and looked at necrotizing enterocolitis and long-term outcomes in babies that were similar category, less than 1250 grams infant across 2 sites. And they were not able to see a difference in necrotizing enterocolitis, but did show an improvement in severe retinopathy of prematurity. But I would say that if you combine those 2 data sets, one will still demonstrate an overall effect. And perhaps one of the challenges with the O'Connor trial was that their numbers are rather small. And so they may have been underpowered to demonstrate a difference. So the way we look at this model then, I think, is to say that not only are we looking to calibrate how much benefit we're providing with mother's milk, but we're also looking to see mechanisms still not well defined, but what are the negative effects of using intact bovine protein in that scenario of the preterm infant. Okay, I like this. It's not a drug trafficking map, but a milk trafficking map, because it really does reflect, for me, one of the challenges of really promoting mother's milk in the hospital setting. Because when you order infant formula, all the work's been done for you. It's been manufactured and it's up to a certain standard, and it arrives to you, and you open the bottle and you use it. When it comes to mother's milk, we suddenly own all these processing steps. Everything from providing the mom a pump, and then collecting that milk, storing it, freezing it, transporting it, thawing it again, mixing it into, whether it's by the bedside or through a milk lab, and then bringing it back out and putting it into tubing and syringes and giving it to the baby. So really, it's a significant amount of responsibility that we have in managing this. And so we need to understand that the product that we're using is, because of its biologic nature, is highly variable. And we knew that for many years, that there's variation in the milk because of the many different factors, whether it's the time of day, the lactation time postnatally, to individual mothers producing different kinds of milk overall, and so this variation is a real challenge. So if you take, just as a simple example, if you take mother's milk and from random preterm moms and throw it on a calorie board, you'll see that only less than 50% of those moms' milk actually read the textbook and was close to the 20 kilocal per ounce. That many of the samples were significantly lower and dilute, and some were even supercharged, or sort of what I call high octane milk, really high up there. And as a result, we recognize that variation is not being recognized or measured at the bedside, and so a baby may experience significant changes. The other aspect that I think is important, that is present across all milk samples over time, is that the protein levels decline, whether it's donor milk or preterm mom's milk, what have you. They all decline, most within the first month, and then subsequently a little bit slower. But if you take milk further out, which is what we do with donor milk, we know that the protein content is going to be lower on average, and in some moms maybe really, really low. And then, so what has that led to? Is led to really some practice changes to try to see, well, how do we fix this? How do we get to know what's in the milk? And so a number of us have tried to take analyzers from the dairy industry and try to see if we can build them into the workflow for the clinical environment. Others have said, well, that's that, before these machines were around, they kind of devised, well, if a baby's not growing, we can use measures like blood urea nitrogen and just accelerate the amount of nutrients we can provide them to give them more for those babies that are not growing well. So it's a sort of a customized way of fortifying, one using very, very complicated and expensive equipment, and others with is more sort of more pragmatic. And I would say that we are not at a place where we can really say that one method over the other is better, still to be debated. And then one other strategy was the use of a human milk derived cream supplement. And that has been shown to have some benefit, particularly in some targeted kids who have high energy needs, like those who are BPD with bronchopulmonary dysplasia, or cardiac babies who have high energy needs. The addition of high energy, so there's no protein really in there, but really giving more energy to some of our babies may be a way to also boost their overall growth. So the concept of targeted fortification, I think, is a good one. And there's really some possibilities of us getting there if we can really uniquely customize it to the individual. But we have to get over the barriers of equipment. There's one device right now that's been FDA approved, and evidence that by doing a specifically targeted fortification, that this is actually going to translate into benefit. And so far, we've not seen overwhelming evidence that using these fancy equipment can lead to, reliable and justifiable, cost-effective ways of targeting growth, over and above being just more aggressive with the growth trajectories of babies. The final thing I wanted to share is really the emerging perspective around the microbiome, or the microbiota, that's found in the environment, but also in our milk, mother's milk. And we know that the unique property of mother's milk is that it is not just containing probiotics, but it's also containing prebiotics. And as such, that represents the perfect synbiotic because of the pre and pro components. And that's important to recognize, because you're born typically with very little bacteria in your gut. It's not zero, because that you can detect some fragments of bacteria, but it's really pretty much clean. And then we know that over time, the natural course is that we populate ourselves with more bacteria than our own human cells, that we create another organ in the lumen of our gut, mostly in the colon. And in that fecal mass is really this other organ that metabolizes nutrients and exchanges with our gut and our colon to provide optimal health. And so having those microbes are in our gut working with us is really important. And it's rather interesting that as we became more aggressive in destroying both virus and bacteria over time, that we have seen a surge in autoimmunity and immune dysfunction with humans. So that we're seeing a lot more scenarios of dysbiosis. And I mentioned that the preterm infant is probably a classic example of a dysbiotic situation. So I think that's something that we are struggling with, because our babies come out, they don't come out the right way through the birth canal, which is a critical inoculum for them. And then they have broad spectrum antibiotics many times. We're trying to lessen that now. We don't feed them. And in the past, we wouldn't feed them for weeks before introducing something. And then if we fed them formula, you were feeding them really just sterilized food, as opposed to bioactive components and immune protective components. And then we've got them in our unit and not in a natural environment. And we know that our unit in the hospital setting has a lot of pathogenic bacteria. And the difference between coming out the birth canal versus C-section is stark. And we know that those that are delivered by C-section, even term babies, have a different risk long-term, that they are altered because they did not get that first inoculum of bacteria from their mother. So we think that may be part of the reason for our preterm babies having delays in their establishment of their flora, but also there are many other factors. The immaturity, I think, is a big factor. So they don't have the right kind of bacteria, they don't establish it in the right time course, and they don't have the right diversity of bacteria. And those that are fed mother's milk versus formula end up having different bacteria that ultimately dominate in their gut. And then to really add to the complexity to that is that mom's milk has, as I mentioned, these prebiotic sugars and the microbiota that are present that are not standard, that every mother, depending on where they live, depending on what they eat, and obviously potentially what their genetic makeup is, they make different, or they house different microbiota in their milk. So it's really almost like a microbiome or microbiota signature of mothers. Mothers make unique microbiome, has unique microbiome, and has unique prebiotics or oligosaccharides. And we can take a look at our disease of interest, NEC, and recognize if you look at their microbiota before a child gets NEC, that already there is an alteration in their profile of what kind of bacteria they have well before they develop NEC. And what's not clear is that cause or effect when NEC occurs. But we do know that the strong implication that the microbiota is critical to maintaining health and may be relational to the development of NEC. And so there's the other component besides the bacteria component that I think we've underappreciated, now only beginning to sort of factor in, revolves around human milk oligosaccharides, knowing that we make a ton of it. It's the third largest component in mom's milk, and that they're genetically determined so that moms are unique in making different sugars. And the sugars are not just, 2 or 3 chains. There are hundreds of different chains in any given mother. So the implication is that these sugars provide the right substrate that favor the growth of good bacteria like Bifidobacter. But it's even probably more than that, because these sugars are not only delivered down to the gut, but some of it gets absorbed into the systemic circulation. So it's no surprise that when you map out the effects of HMOs in human biology, that it protects against a number of different pathogens, bacteria, fungal, or virus, but also against a condition like necrotizing enterocolitis, and in particular has effects on overall intestinal health, intestinal development, and the immune function. So what does the future hold? The future, I think, holds to more and more discovery around human milk and its derivatives, and really optimizing not only for the term infant, which clearly is a more healthy model, but really looking at the most unhealthy scenario of a preterm baby, really taking advantage of the base properties of mother's milk and augmenting that in a way that lacto-engineers the mom's milk to benefit. One of the challenges, and I get this question almost all the time, is, well, let's just feed mom a certain diet and make the milk really, supercharged in one way, shape, or form. And the challenge with that is it's very difficult, that the body is designed to make whatever milk that mom is supposed to make pretty consistently. So there's very little ways that we can really, truly lacto-engineer in gross terms. But there are some ways, and some of the ways relate to particularly the fatty acid profile or the fat soluble vitamins. And certainly if you add medications or environmental toxins or other toxins, that can also be delivered through the milk. But we know that if you had a very unhealthy diet of say trans fatty acids, lots of deep fried food and packaged food that has a lot of trans fats, that a mom can actually deliver a lot of those fatty acids in her milk that are going to be related and correlated with her dietary intake of fatty acids. So that is one way of altering the milk. The other way is, which is I think is now well accepted, is through the delivery of vitamin D, which we know is a fat soluble vitamin, and that moms are always having to supplement vitamin D for breastfeeding. But we now recognize that moms need to take a lot more in order to supplement to have adequate levels of vitamin D in her milk. So there are ways to lacto-engineer vitamins in mom's milk. So long term, we see that donor milk and all the science around donor milk is going to have more impact beyond just the preterm infants. We're starting to see inclusion, particularly of term infants, to satisfy some of the hospital-based requirements, but late preterm group as a target, and even looking at donor milk and its derivatives, cancer, athletic performance, and even wellness. So I think we're going to see some real other applications. And so the big picture when we look at preterm babies, recognize that we are trying to deliver benefits early on to reduce morbidity. And we're hoping that this ultimately translates into long-term health, better brains, better reduction in infection, and better overall quality of life for our babies. And I'll talk in the next group session around the SPIN program. And this was our attempt many years ago to try to standardize our way to center mother's milk into the NICU space and target more mom's milk, more standardized growth targets, and encourage the production of enough milk, and have a proper plan for babies to go home. So you can follow still at the old address. I'll probably be reconstituting the website at my news center, but you can still obtain a lot of the material at the old site. So really the challenge I ask everyone is it unethical now to give a very low birth weight infant formula for the first few months of life? And I used to say there was no medical legal basis to this, and now there's the emergence of a number of cases that are starting to come because of the challenge of this particular dilemma. So hopefully I've impressed upon you the perspective that we still feel that mom's milk is the single most powerful intervention that we can do for our babies, and that we need to really lean on the donor milk community and model to be able to substitute when mom's milk is not available. I think I'll stop there and entertain questions. And I can't remember if the questions are going to come by audio or by chat.
Dr. Kim, this is Linda Kopecky. I appreciate your presentation. I've asked people to submit their questions in the Q&A or the chat section. And I think they're starting to type now, but I'm wondering if Dr. Heggie might have an initial question for you.
Yeah, and maybe I forgot to add these. There's been I've been involved for a number of years with the NEC Society as a parents group that has really formed and really galvanized our community around NEC. And I just point you to their website. And in particular, we've had several conferences, and a conference that was supposed to happen in Cincinnati, but now it's going to be virtual for next year. But I guide everyone to the necsociety.org website where all that information is. So I'll stop there.
Great. Thank you, Dr. Kim. I'm always so impressed about human milk, and I learn something new every time I hear more about the amazing science behind human milk and what we're learning about it and why it's so important. I wonder if you can address NICU discharge and fortification. It often comes up in especially the lactation community about babies getting discharged with fortification in the breast milk. And so are there babies, premature babies, who do not need fortification at the time of discharge of their mom's milk? And also when to stop fortification?
Yeah, those are really good questions. And I think we've probably done a bad job in the literature having the right kind of studies to answer it. The majority of studies that are out there are driven by infant formula supplements as a way to overcome, and even predominantly formula-driven strategies. So we're not going to get the exact answer from the literature. So our approach has been to try to take a look at the risk factors. So an extremely preterm baby, someone who's less than 1,500 grams, and then ultimately gets close discharged, maybe around term age, maybe a little bit before. A lot of them, they're probably a little bit underserved in terms of overall energy, overall growth, and a lot of them miss the target for staying above the, say, the 10th percentile line. And also their mineral delivery probably isn't completely complete at that time. And some of them are growth restricted, as you know, and they are not so great when they get to term age or when they get to discharge. So I think it's pretty clear that those kids are going to need some level of additional support. And what is challenging is, how do you support them? Is it powdered, mixed in with the mom's milk? Is it a formula? Or what I have leaned on, and I'll maybe talk at the next when I talk about the program, I have leaned on the mathematics of it. Like, look at the growth pattern, look at where they are, and look at what you think they need, and then derive the right combination of supplements for them to go home. I'm a huge fan of the liquid formulas that are 30 cal. So there's several different companies that make that. And it allows you to give a concentrated, low osmolarity formula that acts like a supplement and boosts up protein, boosts up minerals in a way that does not impede moms from breastfeeding, because it's liquid. You don't have to be mixing it into mom's milk at all. You can if you want, but moms can continue to learn to breastfeed because they haven't learned completely at that point. They can work on breastfeeding and, in addition, give that little extra boost. As a general rule, we have wanted to recommend at least 3 months post-discharge for the vast majority of those very preterm babies. For those babies that are above that, moderate preterms and late preterms that you started some fortification in hospital, I think a lot of them, they catch up by term age. So that when they get to 40 weeks gestation, they're pretty much, if you look at the growth, you look at what you've been able to supplement them from a mineral perspective, they're probably close to where you want them to be. So for those groups, I think it's pretty reasonable to cut them off once they reach their due date and then monitor. And the only caveat would be those kids that are growth restricted. And then you'd want to be more aggressive with them because we know that they are mineral challenged and they're overall growth challenged. And so you'd want to get them to grow with a little bit more boost in their nutrients.
So this is Linda again. I have a couple questions in the Q&A. So Dr. Kim, the first one is, actually now three. So the first one is, with regards to COVID-19, what are you seeing clinically with those babies born to moms who are COVID-19 and breastfeeding their babies?
Yeah, we've been trying to evaluate our local experience, and initially we had sort of two experiences, one in the normal newborn and one in the, and it'd be great to hear other people's comments about this, but, and then one in the NICU. So if I go to the NICU, I think we really did have some challenges because of the barriers of visitation and separation of mom and baby, large gaps. And so for the NICU space, it was a lot more separation. And we initially had some worry that mom's production and ability to deliver milk and provide for a baby may be hampered. And then when the initial surge decreased, we were able to improve that gap and reduce some of our limitations. On the newborn side, I thought there was an interesting observation that probably hasn't panned out completely. And that was the observation that when we did visitation restrictions and mom and baby initially were fully separated, but then they were allowed to sort of co-share within a room, that mom was able to spend whatever time that she could breastfeeding her baby without all these visitors that normally are present. So we had some initial observation that moms were doing better at breastfeeding in terms of our statistics because we thought because there weren't as many visitors. And then we started to relax our policy and allow for more visitation. And I think our numbers have kind of gone back to normal or to pre-COVID time. So I'm curious whether we ought to really think carefully about the impact that visitation, sort of open visitation in the first few days of after birth, have on a mom's ability to really spend as maximal time bonding and being able to provide milk to her baby.
Thank you. Second question. Are there any studies or general information that looks at how quickly formula changes the microbiome of an infant? For example, if a woman starts exclusively breastfeeding and supplements with formula, how much impact does that have on the newborn gut? And are those changes reversible?
Mm-hmm. So it's not well studied, so it's a good question about how quickly can you modify. So what we know that really modifies the microbiome, one of the big factors are those human milk oligosaccharides. So if a mom is delivering a majority of her milk and you have half a day or even a bottle or maybe a full day of formula, it's not likely that it's going to have a major shift in the flora. That being said, we know that the flora is very dynamic. So in an adult, for instance, you can give antibiotics and then wipe out the bacteria. And then over time, that bacteria goes right back to your baseline, whatever you were before. In infants, it's still formative. So it's not as stable. So going back and forth may create some instability. But the big drivers really are the human milk oligosaccharides and really any pre-existing bacteria that were there to begin with. So if the baby was, for instance, born by vaginal birth and had a normal delivery and had normal bacteria inoculate them, they're going to have much better ability to hold on to a good bacterial flora that's actually very similar to mom's flora in that over a period of time, even if a little bit of formula is introduced along the way.
Thank you. So we have 3 more questions. This one is, in our facility, we teach high-risk moms to hand express prior to delivery, GDM in particular. Some moms are also hand expressing after 37 weeks gestation to practice expressing and also collect colostrum to have on hand just in case there is a need postpartum. These moms are transitioning to mature milk earlier. Are we missing out on any of the benefits of colostrum postpartum if mom is producing mature milk sooner?
That's a really good question. There's been a movement. There's a couple of studies that have looked at, especially gestational diabetes, and trying to be able to have mom's milk available for those babies that have low blood sugar early on. So there's been some sort of data that have moms prepping before delivery, and then they're actually transitioning a little bit of their milk at the time of birth. I'm not aware of studies that have characterized that quality of milk. Certainly if there's high volume milk at birth, then probably that transition is taking place, so there'd be a little bit of a drop. But I doubt that it would be that significant, that there's still a preferential higher amount of bioactive components in that milk, even if there was some pre-preparation of the mammary gland beforehand. But I don't have specific analytic data.
Mm-hmm.
And I think it's an interesting thing to encourage, to look at, more data needs to come out, but I think people used to think that it was unsafe, but I doubt, based on the literature, that's the case. And it may be a way to get moms started before birth.
Thank you. 3 more questions. Regarding late preterm infant born at an AGA weight, when is fortification necessary or not necessary?
So good question, very little data. So most of the effort in terms of looking at nutrient fortification has been in the very low birth weights, less than 1,800 grams even. So you get to the late preterm, which is 34, 35, and 36 weeks, and we really don't have a good handle. What I see is that many places will consider 34 somewhere in that soft spot. And so many places will consider 34 weeks a time to do some fortification. And I think there's some reasonable rationale, particularly with minerals and a little bit with protein, depending on intake. 35, 36 weeks, I could see, there's no data to tell you exactly, but by intake and mineral support, you probably can get away with not fortifying them. But if you have a good fortification strategy you want to incorporate, I think that's reasonable too. I just not enough data to inform us. But the overarching caveat is, if you are IUGR, if you're growth restricted in that group in a late preterm infant, then I can almost guarantee that infant's been significantly challenged from a total growth, energy, and particularly mineral support. So those kids probably deserve some degree of fortification. And the stop point's not really well known, but I think mathematically they are definitely further down and would require more support.
Okay, thank you so much. Next question. Regarding iron levels, cognitive outcomes, and cord clamping. How can we implement delayed cord clamping in preterm infants?
So it's changing culture. I think we even still have some work to do in the term infant for delayed cord clamping, even though the evidence is pretty straightforward. In the preterm, recommendations are there now. So it's about setting it up in terms of a standard within your hospital. In my old institution, we actually had it as a measurable outcome. So we had fields in our electronic medical records that was a checkbox to say, did you do delayed or not? The one challenge are the sick preterm babies that people get anxious because they know they're not doing well, and they're sick and they come out. Waiting a full minute is a pretty stressful thing for the OB side and maybe the neonatal side. And I don't think we have a perfect solution to that. If the baby has not taken a first breath, then, you know, it's still connected to the placenta, some of that placental support is certainly going to be beneficial. But that's still unresolved. And there's been some attempt to do milking of the cord to speed up the process. And that there's an ongoing study right now it's still not clear. But the initial data from that study, there was some concern for the very preterm babies that maybe that's not the right way to go because perhaps it's too aggressive to milk the cord in the smallest babies.
Thank you so much. We have one last question. What is
Mhm.
your opinion of infant formulas that contain a copy of human oligosaccharide?
Yeah, so there were formulas in the past that had plant-based oligosaccharides. So there were galacto-oligosaccharides, GOS, and then FOS, the fructo oligosaccharide. And then recently they put in 2FL, which is a HMO that is found in human milk, but it was synthesized and then put into infant formula, but only term formula. And the early evidence suggests that it's safe and that it does have promotional effect on the gut microbiota. There's no data for preterm babies, and it's a contrast between a prebiotic, one sugar, versus what mother's milk gives, which is hundreds of sugars. So it's a big contrast between those two scenarios. But I think it's a good step forward that we're starting to look at human milk-based oligosaccharides. And there are companies in Europe and elsewhere that are starting to do much greater depth in terms of the oligosaccharide additions and manufacturing. They're looking at other different types of sugars. So I would expect we're going to see more products out there that have prebiotics. What I don't know is if we're going to see it anytime soon for preterm formulas. Probably that's going to take a little bit more time.
Thank you. And we actually have 2 more questions, which is great because you have time. The first one is the Next Society a resource for parents as well as care providers?
Yes, it is. It's meant to, so it was started by a parent Jennifer Canvas, who lost her twin to NEC, and it's been it's meant to be a portal to bring the whole community together. So parents, so there's at least, it's probably over 600 parents around the world. It's international in scope now. And it's brought the NEC researchers, NEC clinicians together as well. So we've run scientific conferences as well as parent-focused workshops and webinars. Right now, we've been doing a number of webinars every couple of months to support the broader community, open to parents and to the medical community.
And it looks like you had the contact information for the Next Society in your slides, and I've sent, and I will do again, I sent the PDF copies of all the slides to the participants and the attendees, so they should have that information. One last,
Great.
2 more questions. One is written consent for use of donor human milk necessary when verbal consent is obtained and hospital admin consent is in place for NICU care?
Yeah, very good question. So it used to be that we really were bound to an informed consent that's written. And what's emerging, and I don't have a real sense of the entire nation, but in California, we've had a couple of groups. And what I'm sensing is that it's much more permissive and much more accepted that one can give verbal informed consent and not have to go through a written consent process. I think we just recognize that donor milk is so prevalent now and accepted as a standard that we probably can start to all move towards verbal consent.
Okay, great. Last question. Can you use fortifiers in hospital for the late preterm who is without other risk factors causing some others to believe their milk is inadequate or not good enough, or for their newborn?
Yeah, so that's delicate. I think we all have to be careful how we message the use of fortification, and in terms of how moms may perceive. I think having a clear standard within your institution is important, and then also discussing how do you message that and why is it important in certain cases to do the fortification. But I do think that being sensitive to that is important, just as it is when we push really hard on the breastfeeding end for the term, healthy term, that we need to understand how did that mom get to the point where they perceive, what's their understanding and maybe bias of what mom's milk is really about.
Thank you. That's the end of the questions. I really appreciate the presentation, but also the thoughtful answers to all the questions. We'll be seeing you later this morning again.
Okay.
So thank you very much. We're going to transition to the next piece of our summit.
All right. Well, I'll see you at the next session then.
Thank you so much. So next we'll be discussing work in Minnesota addressing infant mortality and messages that work. I think I'd like to, I know we have Michelle Chiesa here first, but I think we're going to start with Lasherian McDonald and Tiara Shaw. So very quickly, Lasherian McDonald, I met her just about a year ago and I was so pleased to do so. She's a community health worker, health educator, and a lactation educator, and she's working for St. Paul Ramsey County Public Health. She provides leadership for Club Mom and also the Birth Equity Community Council, which we'll be probably calling BEC from now on. And then also we have Tiara Shaw, who's a community health worker, and the BEC has a wide variety of members, and they definitely have members from the community, and Tiara Shaw is one of those valuable members from the community. And I'll pass it on to them, and then I'll introduce Michelle Chiesa when we're ready for her presentation. So go ahead, Lasherian and Tiara, and pull up your slides.
All righty, I sure will. Thank you for that great introduction. I'm going to share my screen. Go back up to the top. Okay, so can everybody hear me?
Yes, and you just need to put this in slideshow. So if you click on slideshow and then from beginning.
From beginning.
Right there, you're perfect. Perfect. Okay, I'll mute myself so you can present.
Okay, yes. So BEC, the Birth Equity Community Council, we started in 2016 in response to the birth inequities present in the African American and American Indian population. And as you can see, the Birth Equity Community Council, let me get this out of the way. We have a similar model as the evidence-based medicine model. So the evidence-based medicine model has the individual preferences, which coincides to the community voices that BEC has. They have the research, we have data-informed information that we share with the community, and expert opinion, and it coincides to BEC's Partners in Action. So in April 2017, BEC began having a series of community dialogues to have a collective process where action steps address individual, community, and systemic level interventions to promote racial healing and birth equity outcomes. So, the completion of 2019 and 2020 brought engagement with community members and partners, envisioning victories that focuses on 3 main areas. So I will go to that part. So our 3 main areas that you can see are training, celebrations, and policies. So I'll explain a little bit more about what we mean in those areas. So for the training goal of BEC, we want to have by December of 2023 for BEC to co-host 5 training series. The first training series will be navigating the political process. The second will be implicit bias training for providers. The third will be perinatal safe spots and informing the community and the public about what is a perinatal safe spot The 4th is breastfeeding workshops and with community members. And the 5 is just to pass out our findings to the community and to pass out our PSA Safe Sleep messaging to the community. So our first action step for training was identifying our partners and resources who will be available and willing to collaborate in leading these trainings, while Beck just co-hosts them. So for celebrations, we want to celebrate the birth with our Club Mom and Club Dad groups that we have, as Linda mentioned before. So we want to celebrate when the mother is 6 months pregnant, well, the family, we should say, is 6 months pregnant, when the birth actually occurs, and then when the baby makes it past that first year. We want to celebrate all of these with radio announcements, community baby showers, and just providing the families with gift cards, just things to help, just a way to build that village around the family and build support around the family during this time. So our action steps for our celebration will be gathering contact information from the club participants, which we started, and also collaborating with partners for opportunities to increase community acknowledgement and participation in the celebration of these milestones. So for our third action goal, policy, Beck wants to partner with legislators and identify community members and partners to work on paid parental leave and doula reimbursement. So our action steps for policy will be connecting and reconnecting with legislators and re-emphasize Beck's commitment to, lowering the infant mortality rate through doula reimbursement and paid parental leave. And we want to identify community partners to work on these policy areas and who will become allies to help us reach these goals. And so this picture symbolizes when a part of our community dialogues, we ask the community, okay, so what are some things in particular that we can do right now to help lower the mortality rate? And the overarching theme was doulas for dads, or father support in the community and safe sleep messaging. So in this picture, we trained 10 men to be for the Doula Dads program. So 10 men were trained to be certified perinatal educators using the COPE curriculum called the JJ Way. So in this picture, you can see everybody who participated in the second round of training, because we had the first round of training. So we really did leave 10 spots for men to start doing the doula work and supporting men and families during the pregnancy and birthing and, postpartum stages of, bringing a baby into the world. And also, and the overarching theme as far as with the community dialogues, we talked about the implementation as parents as teachers, which we're doing now, and parents as teacher serves both moms and dads with the evidence-based home visiting model that focuses on parent-child interaction, development-centered parenting, and family well-being. And also, as I talked about before with the safe sleep messaging, we did begin to do PSAs around safe sleep, the ABCs of safe sleep, which we would love to share with you all today. So yeah, and I also want to mention that Beck does utilize the Ready, Set, Go framework, which is a nationally recognized city match model for implementing countywide health and healing strategies. So during this time with using the Ready, Set, Go framework, Beck uses the PPOR, which is the period and risk of death for infant mortality. So I'm going to go to that. So this is the PPOR, and up here, these are all the areas that we look at. So we look at the maternal health and prematurity, we look at maternal care, newborn care, and infant health. So in this area, so for the PPOR, and I also want to make a point that BEC, we really make a conscious effort to make sure all of the information, all the data that we have is understood by every BEC participant, whether the BEC participant is a community member or someone who's a nurse. We want to make sure that any and everybody can understand this data, because that's very important to us, so that everybody can know what's going on and why we're doing this work. So in the initial analysis base, it was based on vital records. So with this data, we looked at births, deaths, and field deaths. And later step used other available resources of data and information. So, and this enables the community to better understand and address fetal and infant mortality. So in phase 1, which is the fetal infant mortality map and gap analysis, which you're looking at, so infant and fetal deaths are mapped based on weight, age, and gestational age at death. And study groups who experience inequalities are compared to more ideal groups called the reference group in each period. The different rates between the study group and the reference group is called excess mortality or opportunity gap. So our study groups include US-born African-American women and foreign-born Black women who resides in Ramsey County and Hennepin counties at the time of delivery. The reference group is white women in the same location. So African-American women had greatest infant health, maternal and health prematurity and maternal care areas. So they had the biggest gaps in those areas. And foreign-born Black women had gaps in those areas as well. So overall, what we say is if one group can have favorable or, pretty much ideal birth outcomes, then all groups can have favorable and ideal birth outcomes. So, yeah, BEC, we meet every other month, and right now we're doing it all by Zoom, and we incentivize women from Club Mom or the families that we meet with in the Parents as Teachers program by giving them, gift cards for attending the BEC meetings. And I know that, some of the challenges that we've had since having to switch to do Zoom and things like that. Of course, the biggest challenge is not having us together as one as we usually do, not being able to easily, bounce ideas off of each other by being in the room. It's a different feel when it's online and you have to type things in the chat. So that was just one of the challenges we had, because before everything flew, it would flow more differently. It'll be more interactive. So now that's one of the challenges that we have now that it's 100% virtually and 100% virtually online. And we had to find different ways to be creative to get people more engaged by doing the cloud word activity or doing surveys. So, and I'll say some of the easy things that we've found with doing BEC is that a lot of partners want to help out with this work. When we approach, whether it be legislators or other healthcare providers, when we tell them about this work, they're up for it, they want to do it. So getting the partners of it, was pretty easy, because, we all are in this work so that we can lower the infant mortality rate, in these counties and, America as a whole. So now I'm going to pass it off to our community member to have her perspective, Tiara Shaw, about BEC. So you can get started whenever you want.
Hi, everyone. This has been a wonderful presentation, so thank you for inviting me. I am a community health worker, and I attend BEC and Club Mom. I love both of those meetings that we go to. They really help stimulate you physically and mentally. I'm a new mom, and that's what made me join. So me and my daughter, we love going. I love how we can attend the meetings, and they have professionals to keep my noisy baby for me. And with Club BEC, I really love that it opened up my eyes so much to so many different problems and things that I did not know was a huge problem. And then like they gave me breastfeeding tips and just regular community resources, and everyone is open armed and friendly. And I do agree with LaSherion. The only problem is not actually having the in-person interactions. I really look forward to all of those meetings, and as long as I don't have to work late, I make it my priority to attend. And I really, really miss the activities a bunch that we used to do. We still do them now, but they don't quite feel the same virtually. But they both are very informative, and they help me and my daughter to learn and grow together. So I always encourage everyone I know that have children or that wants children to come out to both of these meetings with us, just because it's very informative for new parents. Thank you.
Yes, thank you so much, Tiara. Yes, Tiara has always been so active in both groups. So we definitely have to have her come on. And she reminded me, yes, I have to talk about a little bit about how Beck was ran before COVID. So, because now we're so wrapped up into it now, I'm just automatically talking about the Zoom portion of it. But before COVID, we did have childcare. We'd have students from Bethel watch the children while the parents come in and share their voice about ways to lower the infant mortality rate. We also provided transportation for the parents if they needed it, and we offered a meal as well. So, yeah, hoping to get back to that sometime in the future. So, any questions?
So I'll look at this is Linda. I'll look at the Q&A and see if there's any questions, or maybe there's some in the chat section. Any questions yet? Perhaps I can ask one question, because we're definitely talking about the intersection of infant mortality and breastfeeding. Here's a question. No. Yes. So this question is, do you have a list of community resources that you use?
By community resources, do you mean like as far as like organizations, or you mean like as far as we give out resources for like housing? Because we do have community partners. They include the African American Babies Coalition, ICHIRP, which stands for the Integrated Care for High-Risk Pregnancies, the Minnesota Breastfeeding Coalition, Minnesota Department of Health, St. Paul Ramsey County Public Health, JAMA Place, University of Minnesota Medical School. So we do have partners, and of course, they're businesses. So do you mean what type of resources?
I know Tiara mentioned accessing resources when coming to Beck meetings.
Oh, okay. I'll say we do have speakers who come sometimes, just to talk about as far as breastfeeding. Like, you came, for an example, Linda, when you talked about the baby behavior training. So that was a resource that was shared, and a few Beck participants, you were able to set aside some seats for them to attend that and have that learning. So yeah, we do have speakers who come and talk about any activities or engagements or things like that they have coming up that they make accessible for the Beck participants.
And then this person clarified that question is exactly what she was going for, the groups and organizations that help in specific areas. So another question is, does your program specifically include prenatal breastfeeding classes?
Prenatal breastfeeding classes. No, but that's what we want to do. Beck ourselves, we don't have prenatal breastfeeding classes, but we do want to we are in the process of co-hosting breastfeeding classes for the community.
Okay, 2 more questions. One is, where can I find information on your training offerings?
Oh, well, you can contact me, or I can contact you, because we definitely want people who are willing to lead a training. We co-host it, so we definitely can share.
This is somebody in St. Cloud, and I can get her information to you, LaSharian. She's one of the presenters tomorrow. And then last question is, are there certain OB clinics, and I'm thinking in the Twin Cities area, that champion the care of women of color?
Certain OB clinics, that champion the care. I'll say not that I'm aware of. I know that for iChirp, there are a couple people from different clinics on there, but I can't think of the name of the clinics right now on the top of my head. I just know of a lot of community resources like New Diva, Club Mom, you know, programs like that focus on the prenatal care of, you know, African-American women and American Indian women. But as far as the OB clinics, I don't have any right now at the top of my head. Not to say that they don't exist, but I don't have.
I'm sure there are folks on this call that may know. I'm thinking North Point in Minneapolis. There are probably others.
Yes.
But thank you so much. I'm going to move on to Michelle Chiesa. And
No problem.
North Point, yes, somebody was mentioning North Point. So
Okay.
thank you so much.
No problem. I'm gonna stop the sharing.
So, perfect. And our next presenter is Michelle Chiesa. So I was I haven't met her in person because I've encountered her through the Birth Equity Community Council, and she's the State Infant Health and Mortality Reduction Specialist. And I see, Michelle, that you are already pulling up your slides, and I will mute myself so you can present. Thank you so much. Don't forget to put this in slideshow. Click on slideshow. Right, and from beginning, and then perfect.
Can you hear me now? My computer wouldn't unmute.
Yes, we can hear you, but you need to go back to presenting from beginning. Click on beginning.
I clicked on it, but it wouldn't do it.
Yeah, it did it for a moment. Resume slideshow.
Okay, there we go.
Perfect, thank you.
Perfect, thank you. Good morning, everyone. My name is Michelle Chiesa, and I'm the State Infant Health and Mortality Reduction Specialist at the Minnesota Department of Health. I provide statewide leadership around infant mortality reduction. And today I'll just be providing some quick updates on the state's infant mortality safe sleep initiative, as well as on SUID. So my presentation today covers the definition of SUID. We'll define that, provide some quick data on SUID in Minnesota, highlight some risk and protective factors for SUID, discuss in brief health equity and in the context of SUID prevention, and provide some examples of current MDH efforts to reduce sleep-related tragedies. So every year in the US, we have about 3,600 what we call sudden unexpected infant deaths. In Minnesota, we have between 350 and 380 infant deaths annually. And of those, about 50 to 60 are SUID. The majority of SUID in Minnesota are sleep-related. And as you can see from the data that's presented before you, between 2016 and 2018, out of the 141 SUID deaths that we had, about 119 were sleep-related, and I've seen even much higher percentages than what you see before you. So what exactly is SUID? SUID is a subset of infant deaths. These are deaths that occur suddenly and unexpectedly before age 1, before baby celebrates his or her first birthday. And when these deaths happen, because the cause of death is not very obvious, then investigation is needed, including an autopsy and a review of the child's medical history. Most SUID that we know of occur during sleep. For example, suffocation. And I also want to share with you that a lot of these deaths that we see, they're largely preventable. Now, there are many different types of SUID, the most common of which or the most common type that people know is SIDS, but there are others like suffocation, asphyxia, and ingestions, and so forth. These are just different types of sudden unexpected infant deaths. In the US, the 3 most common types of SUID deaths are sudden infant death syndrome, or SIDS, or what people call SIDS, deaths that are classified as unknown, and accidental suffocation and strangulation in bed. And I'm going to sort of explain SIDS is very common. These are examples of accidental suffocation and strangulation in bed. A lot of people don't know about these types of deaths per se, or the mechanisms through which, for example, suffocation occurs. But suffocation can occur from soft bedding, pillows, or on waterbed mattresses, or any soft surface, even on couches. These accidental suffocation and strangulation deaths, they occur a lot of times because of overlays, right? Somebody is sharing the bed with the baby and they accidentally roll on top of the baby. And wedging and entrapment, these are deaths where maybe the baby's on a sofa and the baby gets caught between the back of the sofa and the cushions on the sofa, or the bed is against the wall and the baby gets strapped between the bed and the wall. And then there's strangulation, which because maybe the crib slats are too loose, the baby's head gets caught in the middle of those slats, and that causes the baby to strangulate and die. Now, SUID can happen during any time during the first year of life, during the first month, what we call the neonatal phase, or the postnatal phase, between the 28th day of life up to the first year of life. And SUIDs are actually the leading cause of postnatal mortality in the US. There are many sort of risk and modifiable risk, and there are also protective factors and other factors that are implicated in these SUID deaths that we see. For example, prone and side sleeping. We all hear the back to sleep messages. A reason why we give that, because that is probably the strongest evidence we have that when you put baby on back to sleep, that reduces their risk of dying suddenly and unexpectedly from suffocation, overheating, from choking, that sort of thing. And this is universal. When babies sleep on soft surfaces, that's why we say a firm sleep surface like a mattress or a crib or a bassinet, that's safety approved. Maternal smoking, we know, is linked to a whole host of adverse health consequences for mothers and babies. Of course, low birth weight and preterm births are implicated are related to maternal smoking, and they're also implicated in SUIDs. They're also risk factors rather for SUID deaths. Environmental tobacco smoke is one of those risk factors that are also modifiable, but also related to SUID deaths, SIDS in particular. That's the deaths that's been highlighted in particular to these kind of risk factors. Bed sharing or co-sleeping, overheating, putting baby in too many layers of clothing and then having blankets on top of baby can increase the risk of overheating. And then not having any prenatal care, or just not, or starting prenatal care late. Prenatal care is very important in mitigating some of these risk factors through education and that sort of thing. Breastfeeding is, of course, very protective. And our very first presentation this morning, Dr. Kim, I believe his name, he gave a wonderful presentation that sort of really highlight the importance of breastfeeding, which is like gold standard. That's the best source of nutrition for baby, and why it's so important and protective. And it's also related to it. Also, when mothers don't breastfeed, babies have a greater risk of dying suddenly and unexpectedly. There are also other factors which are non-modifiable. For example, being Black or African American and American Indian, babies who are born to these two groups of women have a greater risk of dying suddenly and unexpectedly. And we don't want to blame these moms, because it's not just about behaviors, mother not putting the baby to sleep in a crib. Maybe the mother doesn't have a crib for the baby. So we don't want to blame families, but these two groups are at greatest risk. Now, like any type of infant death, SUIDs are complex, and it takes a whole lot of factors sort of acting in concert with one another at different levels, individual level, systems level, environmental and community factors, acting in concert to determine whether a baby is at risk for dying suddenly and unexpectedly before age 1 or surviving to celebrate their first birthday. Now, so what do we know about SUID in Minnesota? We know that it's a leading cause of infant mortality. From the data that we have from 2012 and 2016, I don't have any more current data than this to share from the birth or death record. We also know from those years that the risk is greatest. It's the third leading cause of death among African Americans and also among non-Hispanic white. What surprised us in these data is that it wasn't a leading cause of American Indian. For many years it was, and obstetric conditions became the leading cause, and probably because of opioids and that sort of thing, we hypothesize. We also know that the rates have varied over time in Minnesota. We also know that there are variation in rates among different racial and ethnic groups. Here we see the infants born to Native American or American Indian women have the highest risk. It's 12 times greater than the risk among Asian Pacific Islanders, who have the lowest rate, and that's consistent. And we also know that the rate among Native Americans is also 8 times greater for the data that we have for 2014 and 2018 than it is among whites. So, and we also know that that Hispanic infants born to Hispanic mothers are at greater risk than those who are born to women who are classified as non-Hispanics. The other thing that we know is that more than half of the SUID deaths that occurred between 2014 and 2018 occurred in our metro area. So there's geographic variation as well. And we also know that among those deaths that happened between 2016 and 2017, what we found was that 85% of them the babies weren't sleeping in a crib in a safe space. They had objects, soft objects, maybe a pillow or blanket or something in the crib that maybe caused suffocation. Then we also know they were sharing a sleep surface, maybe co-sleeping with someone else, or could be an animal or something else in the space. And then they were in an unsafe sleep position, such as on their side or on their stomach. And we also have additional data that tells us about how mothers are putting their babies, how and where they're putting their babies to sleep. That comes from the Pregnancy Risk Assessment Monitoring System, or PRAMS for short. Here we see data from 2016 to 2018 that shows us the percentage of mothers in Minnesota who reported where their babies slept in the past 2 weeks. We see that they said yes, that a greater proportion, 88% of them said they put their babies in a bassinet, crib, or play yard, which is great, but we'd like for that to be closer to 100% or even 100%. Even though more than half of the mothers reported that they're not sleeping, putting their babies to sleep in a swing or using blankets and that sort of thing, even though those proportions are greater than 50%, there's still more work to be done. So the 41, the proportions in the 40 range, there's more work to be done. Those numbers should go way down, even 0 if we could. So we also know that mothers in Minnesota are putting their babies back to sleep, but there's also more work to be done from the data that we have. Like more than 80% of them say that they are putting their babies on their back to sleep, which is encouraging. Then we also know that breastfeeding, of course, is very important. That's why we're here today. But we have some concerns about the breastfeeding rates. Mothers are reporting that, you know, they're either breastfeeding currently or they're feeding their babies pumped milk. And we have concerns about, of course, the US-born Black population and the American Indian populations who are reporting that they're doing this less than maybe Hispanics and white mothers. So what efforts do we have at MDH to address SUID? We have the initiatives, several initiatives that are going on. Our Safe Sleep Initiative, which is part of a bigger initiative to reduce infant mortality at MDH. And our goal, one of our aims, is to prevent sleep-related tragedies from happening by promoting infant safe sleep messages and that sort of thing. And our goals are also, one of our aims is to reduce disparities in SUID rates. And one of our goals is also to reduce the SUID rate by 15% or more by 2022. So it's going to take a lot of work and a lot of people doing this work to make this happen. Our work is guided by the American Academy of Pediatric Infant Safe Sleep recommendations. Our work is guided by clear and consistent, relevant and timely information and messages. And we also aim to put those kind of messages out. work is guided by data and evidence. I just shared some of the data with you that came from either the Sudden Death in the Young SUID Case Reviews Committee, which is a committee of medical examiners and other experts, including myself. We sit in a room and we review cases of sudden unexpected infant deaths. Then we come up with recommendations to improve systems and so forth to make changes. We have data from the Pregnancy Risk Assessment Monitoring System and the Vital Registration data, which are birth and death records. But the Pregnancy Risk Assessment Monitoring System is a survey between CDC and MDH, which is aimed at collecting information from mothers, pregnant mothers about their experiences before, during, and after pregnancy. So moms who've given birth to newborn. And then our work is guided by health equity principles, and that is very important to us. Why health equity? Because one size does not fit all. A lot of people conflate equality with equity, but they're different. Equality means sameness. You give everybody the same thing, but it may not fit or suit everyone. Here you see in the picture, the same size bicycle is given to everyone, and it doesn't suit them all. But equity is about giving people the opportunities and the resources that they need to maximize their health potential by making sure that that resource is appropriate and the opportunities are appropriate for them to facilitate the kind of change you'd like to see, or behavior, or whatever kind of change you'd like to see. Our work is guided by the social ecological model, which shows you the different layers and influences that are at play in influencing SUID outcomes. It takes work at different levels and multiple levels to reduce SUIDs, not just focusing on individuals. Although these different levels, whether it's the structures, policy systems of a community level, institutional levels, or organizational levels and interpersonal levels, can exert influences on individuals in terms of how they behave and their knowledge, attitudes, and beliefs and behaviors. So it takes all of these levels influencing each other to bring about SUID reduction or infant mortality reduction more broadly. So we're part of the National Institute of Child Health, Child and Human Development, NICHD, Eunice Kennedy Shriver, NICHD, Safe to Sleep campaign initiative. That's a national initiative aimed at reducing sleep-related tragedies. It used to be called Back to Sleep, which was implemented in 1994. And that initiative has been responsible for about a 50% reduction in these sleep-related tragedies since its inception in the mid-90s. So these are just some of the brochures and not brochures, but booklets and flyers that are available to individuals. Anyone who takes care of babies should really have this kind of information. And they're attempting here to make them culturally appropriate. You see different babies of different racial and ethnic backgrounds reflected on the materials, and they translate the materials in Spanish. And what does a safe sleep environment look like? That's probably the most popular because it's just one sheet back and front with all the information that anyone who takes care of babies need to know about keeping babies safe during sleep. We distribute these, and they can also be accessed through our website, and they're free of charge, so anyone can gain access to them. They're also at the individual level. I try to mesh the individual and the interpersonal levels kind of together. We just don't target families, right? Moms and dads who have moms who have babies. We also want these messages to go out to dads and grandparents. We know grandparents, they gave birth to their children many years ago when they thought it was okay to put babies on their stomach to sleep. Sometimes it's hard to change their knowledge and beliefs about safe sleep. So this is the NICHD's attempt to reach out to them. And you see they have these brochures in Spanish, the safe sleep resources targeting grandparents. And they also target fathers with their messages, and we also participate in those. We also participate in that part of the initiative to make those resources available. They also target more specific groups than that, healthcare providers and the Native American population. There's a training with a work kit, the one in the middle, that's available, as well as they target breastfeeding mothers. There's a series of videos on their website that anyone can access, of course, again, free of charge, that address the safety of baby during breastfeeding. And it's not to say that safe sleep is more important than breastfeeding, but both are extremely important. One should not, it's not safe sleep over breastfeeding or breastfeeding over safe sleep. Both are very important because the ultimate goal is to make sure that babies survive, they thrive, and they develop, and they can, they grow up to be successful people one day. So that's the ultimate goal. Now, the resources that the NICHD offers, they don't always translate everything into multiple languages. And here are some ABCs of safe sleep quick cards that we have available that we developed in-house at MDH that were widely distributed at the State Fair for at least 2 to 3 years. They first were produced in English. Then we decided to translate them in many languages. Here we see them, they're available in English and Spanish and Somali and Hmong, but we also have them available in Oromo and Amharic, which are 2 Ethiopian languages spoken in Ethiopia, as well as in Russian and Karen language. So they're available in other languages if anyone is interested in them. They're on our website and they're free of charge. Here we're trying at the organizational level to make changes across systems. So one of the initiatives that we're currently working on is one with the Crib for Kids, National Safe Sleep Hospital 6 Certification Program, which is a recognition program of hospitals that put strategies in place to keep babies safe. One is, for example, they offer this certification or designation at 3 different levels: the bronze, the silver, and the gold. The bronze is the most basic level. At the minimum, they want hospital leadership or anyone who works in hospitals to have a safe sleep policy in place, to provide training to their staff, and to counsel families before they leave the hospital. And the levels just build on themselves, and then hospital can become certified at any level free of charge, and the requirements build on themselves to where at the goal level, any hospital participating in this sort of initiative has to do some community outreach and do a QI and that sort of thing. So this is an initiative that's going on currently. We have a nurse on staff who is helping us with this, because we're going to become more aggressive about recruiting hospitals. We currently have 2 hospitals that are certified in our state, one at the gold and one at the silver level. Hennepin Healthcare is at the gold level, and St. Luke's up in Duluth is at the silver level. And we recognize hospitals for they get a lot of publicity when they become certified. The other thing, the reason why we want to do this, the certification is so important because providers play an important role in educating their patients about infant sleep safety. And from the data that we have, they're doing a good job, but we think they could do a lot more about talking not just about back to sleep, which a lot of parents seem to be getting that message, but also about the other related messages like not having stuff in the crib and that sort of thing. So that's one of the reasons why that's so important. At the institutional level, we have a whole lot of things going on. I couldn't possibly list everything. From the MDH side, we provide trainings and presentations like these. This is a little bit different from others that I've given to organizations upon request. We've done trainings with the Native American population up at the Fond du Lac Reservation, for example, provide trainings to DHS grantees who are providing services around substance abuse prevention. We do that sort of training, and it's very fun and involves vignettes and practical things, on-site demonstration of safe sleep, a whole lot of things. We also provide technical input into policies and trainings and safe sleep messages and other products statewide. We work closely with DHS, for example. And recently I was part of a work group, a legislative work group, where we were charged to review the current statute, Minnesota Statute 245A.1435, which addresses how babies should sleep in childcare settings. And so we were updating the language, and then our initiative drafted, and if the MDH side, me in particular, drafted this FAQ that anyone can access with some questions around safe sleep that's targeting childcare providers. Then there are other statutes that MDH has to adhere to. For example, we at MDH are required to provide what's called safe sleep, a data collection tool to scene investigators. We in policy must make that happen for them so that they can have the tools they need to collect the information so we can better ascertain the cause and manner of sudden unexpected infant deaths. Then there are other grants that are in statute, like the Positive Alternatives Grant Program, which provides resources, which provide grants to nonprofits to provide services to pregnant, low-income pregnant women. And one of the things they do very well is to, they fund an organization, several organizations to distribute cribs statewide and to provide safe sleep education to pregnant and parenting women to change the narrative around that. We also have lots of partners. We can't list them all, but there's a list at the back. We work very closely with local public health. We work with community-based organizations. Beck is one of our biggest partners. Work with La Charion very closely. We work with childcare providers. We have a lot of community champions. We go on the radio in the African-American community with our African-American community partners, and we talk about safe sleep and how to keep babies safe and the risk and so forth. And then the Minnesota SIDS Center, MDH once funded this SIDS Center partially, and the SIDS Center, I have to say, was so instrumental. They closed in 2017 in changing the knowledge, people's knowledge about infant safety and in providing trainings and so forth. So I can't thank them enough. Kathleen Fernbach. Then there are lots of federal policies. So like I said, it's not just individuals who need to do work around safe sleep. It's a whole lot of things that have to come together simultaneously to make safe sleep happen. So we provide leadership around infant sleep safety at MDH. There are statutes in place, like Minnesota Statute 2458.1435, which is a medical directive that MDH and DHS worked on together with partners, with our other partners, that requires non-supine sleep positioning license, that if a childcare provider wants to put a baby in the non-supine position, like on the stomach, they have to sign a medical directive. The parents have to sign a medical directive to make that happen. And there has to be written consent required for swaddling to happen and that sort of thing. So these statutes are there to help to keep babies safe in childcare settings. Then there were other initiatives at the national level, funding from Title V that goes out to local public health to help their population learn or understand more about safe sleep, among other infant mortality reduction sort of messaging and efforts. Minnesota was once part of what's called a national COIN, which was a national effort to reduce infant mortality, and we participated in their safe sleep strategy team. And out of it, we worked on, that's how the hospital safe sleep certification started. Among other things, Infant Safe Sleep Week, which I'm about to talk about later. And of course, we partner with this NICHD. So Safe Sleep Week in Minnesota, that's something that's now been institutionalized. We've been doing it for about 6 years now. Next week is Infant Safe Sleep Week in Minnesota. It's usually triggered by a proclamation. There's one currently on our website that's been up for this next week. During that week, we have social media activities that's posted by MDH, a whole lot of things happening. We illuminate bridges. I-35W bridge will be illuminated on November 10th from sunset to sundown. And the Laurie Avenue Bridge will be illuminated by Hennepin County. We're partnering with Ramsey County and Hennepin counties this year, as well as DHS and MnDOT, to make this Infant Safe Sleep Week come alive. And so that bridge will also be illuminated. There's going to be a press release that covers COVID in relation to safe sleep. And sometimes we have a press conference. We had a press conference last year at Hennepin Healthcare when they became gold certified through the National Safe Sleep Certification Program. And then there's a Safe Sleep book campaign, which we kick off immediately following Safe Sleep Week. So that's coming up pretty soon for about a month or more, where we give out Safe Sleep books, and they're free of charge. Shipping is free. If you're interested, let me know in getting some Safe Sleep books. So that's what the press release looked like from last year. And like I said, we could not do this work without our partners. There's so many of them. And infant mortality reduction is not just about safe sleep. It's about so many things. It's complex. So these are some of our important partners. I couldn't list everyone here because then I would need 2 or 3 pages. And that's all I have for you today. And, safe sleep saves lives. So that's it for me.
Thank you, Michelle. Really appreciate this presentation. This is Linda again, and I'm going to, very good. Okay, so we have a few questions for you. We're bumping up against our break time, so we'll ask you a few questions, and you may have already covered some of this because some of these questions came in mid-presentation, but feel free to repeat yourself. The first question is, does the MDH Safe Sleep Initiative include efforts leading to increasing breastfeeding rates, particularly prenatal, education about breastfeeding, and support after birth? And I'm going to combine that with another question about reclaiming cultural and historic breastfeeding.
I'm sorry, what's the last part?
Does the prenatal education include reclaiming cultural and historic breastfeeding?
At this
Connection between your work and breastfeeding.
Oh, sorry. At this point, we don't have that sort of training. Is that what it is, or initiative as part of our Safe Sleep Initiative work? But Marsha and I, we are going to be talking a lot about things that we can do around breastfeeding. We've started, to work together a lot more, and so hopefully we will have some things come up. One of the things, in the past we had what's called a Safe Sleep Work Group, so that's something we're considering resurrecting. Linda Deck, who I see on this, was part of this summit, was part of that group, and so that's something we're considering resurrecting because there's a lot of other work that we'd like to do, and to move just beyond even individual behaviors to focusing also on some social determinants of health, because it takes more than just changing behaviors. That's very important, but we also have to address those other conditions that may lend themselves to families putting their babies maybe in unsafe sleep places, like maybe housing, for example. So we are going to be exploring a lot more than just messages.
Well, I want to say that the Minnesota Breastfeeding Coalition would love to be on this work group.
Yes, definitely. We'd like to make it a bit broader, yes.
Next question, we teach safe sleep. This is somebody who says, we teach safe sleep per American Academy of Pediatric recommendations. We all know parents may or may not follow this. We have a certified nurse midwife who is adamant that we teach that, and Safe Sleep 7, which talks about if you do sleep with your baby, do these things to make it safe as possible. Any thoughts about this?
Yeah, that's a very, I know that's also a very controversial issue. I know it's very difficult to change behaviors, but some people advocate for meeting parents where they're at. As somebody at MDH, I wear a kind of cloak of putting out the best messages possible. And I think each individual provider has to work with their patient in determining or coming up with a solution that's best for that family. So I think that's the route to go, is to come up with a solution that's best for that family, whatever works for that family, and that family will stick to it. That you're putting the baby at risk, but some harm reduction approaches would help. That's individualized to that family, to their specific circumstances.
So here's a question that's similar, is how do you counsel families who have read information about safe sleep on the internet, showing data about breastfeeding and a safe sleep environment?
Who have encountered what kind of information?
Safe sleep information on the internet.
Is it good information or bad information? If it's bad information, you can do some, conversational strategies, talk back kind of strategies. Those also help to reinforce messaging that's positive with the families or clients that you're working with. Because I know that there are either good messages or bad messages on the internet. So if it's bad messages, those are some of the strategies or techniques that you can use to reinforce those good positive messages.
Two questions. Do you address mothers sleeping with babies while breastfeeding? It's a common practice?
Mm-hmm.
And is that addressed?
The resources that we use from the NICHD do address that. And like I showed earlier in one of the earlier slides, they do have a ton of different videos on their website that anyone can go and take a look at. That they're very small little videos that kind of provide some guidance around how to navigate that breastfeeding and the safe sleep issue. And I clicked on some of them. I thought they were pretty good. talks about, feeding your baby on a couch and all kinds of different things. There are quite a few of them out there.
Somebody mentioned the word breast sleeping, which we've been hearing more often. Last question is, and this is maybe something you can provide at a later time and I can send it out to the attendees, is the SUID umbrella and all the types of SUID underneath. Do you have a breakdown of the percentages of those terms? And what are the top 3 types of SUIDs? And we're moving into the break time, so I'm wondering if that data is something you can send to us and I will send out to the participants.
I'd have to ask the people who work on SUID. I don't know from the work that we do in the SUID subcommittee. I don't see it at that level. There's another committee that's above that, and I don't know if they have those data, but I certainly could ask.
Okay.
Certainly if they have other kinds, yeah.
So thank you so much for the presentation. Great information about the local level and the state level work on infant mortality reduction and particularly safe sleep. Thank you. We're going
Thank you.
We're going to move into our break now. And we have a 10-minute break. It's actually going to be more, it's going to be closer to a 5-minute break. We're going to reconvene at 10:32. And I'm going to pause the recording because we have 4 people who have phoned in. And after I pause the recording, I'd like to just ask you to tell us who you are, because we need to connect your phone number with who you are so we can make sure that you have a record of attendance and that we send you the evaluation. So 5-minute break until 10:32 or 10:33, and I'm going to pause the recording now so we can identify the folks who have phoned in.
It can often be very inspiring to physicians who are, and providers in general, who are learning about the amazing things about human milk that many of us haven't learned about in medical school. And I think it's really about integrating breastfeeding and human milk feeding into regular pediatric care and OB care and family care and medical care, so that it's not a carved out thing. Okay, breastfeeding's over here, and when we do the rest of medical care, it's just hardwired in. It's what we do. It's part of general pediatrics and hospital care and maternal care. So yeah, I'm wondering about people's reaction to Dr. Flood's video as well.
So I just have to say what particularly moved me with Dr. Flood's video is the comment about working with the patient who came into the ER with an infected C-section wound, and would she have noticed that the mom needed to breastfeed the baby that was in the car seat across the room? Would she have noticed that if she hadn't been a breastfeeding parent herself? And I think that's important. You know, our own experiences, our own life experiences help us be better providers, better counselors, better teachers, better clinicians.
I think also, this is Carol, from my perspective, I've seen nurses also when providers may not have noticed because they're so focused on what they're working on. Nursing is a great advocate for these mothers. And they would call and say, we need lactation, or we need support for pumping, or we need to help this mom and babe together, or the medications that they're on. It's they're also partners in this as well.
Mm-hmm. So a couple, one comment in the question and answer is medical schools need to teach all providers across all specialties about lactation. And I don't know if that's being done. I know that there are a few medical schools that actually do have mandatory lactation sections, but it's just beginning. Another comment in the chat section is still heartbreaking that even in the medical field, women residents are still shamed about needing to pump or wanting to breastfeed their children. Just wondering if there's any other comments or reflections. The next section, there's one more. This is one of our MBC members. As a retired RN educator, I can say that if it's not on their boards, it's not emphasized in their academic program. And here's a comment in the chat section. Thanks to all the champions presenting today. Questions. I know the current executive director of the Minnesota American Academy of Pediatrics is very supportive and an advocate for lactation, breastfeeding, and chest feeding, but how can the docs we have involved advocate amongst themselves to help move practice standards and elevate the need for regional work together on the continuum of breastfeeding? It seems like our champions are so siloed in our region. I don't know if there's any comments on that.
Well, I would say something about that. I think, like with health equity in a lot of medical centers and in healthcare programs, committees are incorporating health equity into everything they do. It's just constant. And there's always a health equity lens for any kind of policy that's being developed within a hospital. And I would want to advocate for breastfeeding and human milk feeding in the same way, because the siloing comes when people are putting breastfeeding over to the side of, that's nice to have, but it's not integrated into our regular medical care. And so if you have it integrated, you have someone who is representing breastfeeding, human milk feeding, on every single committee that has to do with moms and babies and families, then it becomes more integrated into the best practice of the medical center, which is part of the Baby Friendly Hospital Initiative, which we'll talk about a lot tomorrow. And it was nice hearing Michelle Chiza talk about the infant mortality reduction, where they would have a committee and invite people who are advocating for breastfeeding to their committee meeting, because again, it needs to be integrated into everything that we do rather than just a breastfeeding initiative. It's an infant feeding, an infant health, a mother-baby family health, population health initiative.
And as Dr. Flood said in her video, that traditionally OBs see breastfeeding almost as opposed to the care. They're happy to have mother and baby doing well, and it's less opposed to that. It's part and parcel of mother and baby doing well. This comment in the chat section is, I work in a neonatal acute care setting. More and more decisions are based on reimbursement as well as direct profit. This type of program reminds us how health data and outcome data need to be continually kept on the front burner. Any comments or reflections on that statement? But I just want to say that I am not surprised. I feel like if something is going to happen in the medical setting, it needs to be paid for. And that's the impetus. If it's reimbursable, or if we can pay for it, we will provide it. I think if there's no other comments or reflections, I want to say again, I so appreciate Dr. Flood and Dr. Martin for providing their testimonies. Tomorrow we'll have another testimony from Betsy Yang, who's an RN, and it's about her personal experience, and we'll continue this storytelling as part of our workshop. I want to move to our next section today, talking about milk banking. And this is a sort of a panel, and we're going to be having 3 shorter presentations and then more of an extensive question and answer section. So the first 2 people to speak are from the Minnesota Milk Bank. And Linda Deck is the executive director for the Minnesota Milk Bank for Babies in Golden Valley. And then the second person will be Jill Lindquist, who has been a lactation consultant for over 25 years and was an original board member for the Minnesota Milk Bank for Babies. So Jill and Linda and Jill Lindquist will be giving an update on the Minnesota Milk Bank for Babies, MMBB, and how to safely and efficiently use donor milk in human settings. And after their presentation, we'll go quickly to Dr. Kim, who will tell us about the SIN program, and then we'll have an extended question and answer session for all 3 panelists. So I'll turn off my camera and my microphone now, and I'll stop sharing. So Linda, you can.
All right, I hope you can hear me. And let's see, we should get.
I can definitely hear you. No slides yet.
Let's see. Slideshow. Let's see if that works.
Perfect. Thank you.
Okay. Try not to cut anybody off here. All right. Thank you for that introduction and started here. I think I've been here at the Milk Bank now for a little over a year, after almost 10 years at the Minnesota Department of Health WIC program. I'm happy to share that after several years of dedicated volunteers.
Linda, just a moment, please. There's some, people are hearing some ringing or reverberation. I wonder if you need to do something with your microphone or your speakers.
Hearing an echo, so.
Yeah, it's a little echo. It's like more of a metallic vibration.
Well, let me switch to my computer audio and see if that helps.
Okay.
All right, can you still hear me?
That seems to be much better. Thank you.
Okay, thanks. After several years of dedicated volunteers who raised funds and provided education about donor human milk and about milk banking, the Minnesota Milk Bank became a reality, and in 2019 became an accredited, were accredited by the Human Milk Banking Association of North America. So I'll be sharing a little bit about the milk bank and how the Minnesota Milk Bank processes our donor milk. And then Jill Lindquist, who is still currently the board chair for the milk bank, will share about safe and efficient use of donor milk in a hospital setting. Let's see, so here are our objectives for today's talk, which you should have in your notes, and then our disclosures as well. I think Dr. Kim mentioned earlier very well in his talk about the policy statements that the AAP and also the Canadian Physician Society have about recommendations for infant nutrition, being that it's preferably in order mom's own milk from Fresh is Best and directly from the breast. And then after that, pasteurized donor human milk, and then formula if needed. So go through that again. So just to give you a little bit of background on the Minnesota Milk Bank for babies, started out as an effort, and I think Dr. Kim also mentioned this too, it takes several years for something like this to actually come to fruition. And in 2012, Breast Milk for Babies began when it became established as a nonprofit. And during that time, it did fundraising through grants and donations for the purpose of getting a milk bank in Minnesota. They also provided education about donor milk and milk banking. I think those of you who have attended past summits probably have heard sessions that were offered in the past about donor milk and getting a milk bank established in Minnesota. And it was an effort that took several years, and I think it really made a difference in terms of finally being able to become established. So as it moved closer to achieving its mission, Breast Milk for Babies changed its name to the Minnesota Milk Bank for Babies in 2018. And it selected a site, equipment was purchased, and work towards licensing and accreditation began. So, and in 2019, a new team was put together to take the milk bank into its next phase. And by December of 2019, the Minnesota Milk Bank was accredited by Humana and also licensed by the Minnesota Department of Agriculture as a food manufacturer, and we began dispensing to hospitals. And then just this last part here, we just updated our logo in September and are starting to use this in materials and whatnot. So you'll be seeing that more and more around. Just so wanted to mention that the Minnesota Milk Bank's mission is to improve infant health outcomes by ensuring medically vulnerable babies in Minnesota and the upper Midwest have access to safely pasteurized life-giving donor milk when mother's milk is unavailable or in low supply. And in our first full year of operation, of which we're in our 11th month now, we're still building capacity and focusing on serving Minnesota hospitals and babies before expanding to other states. So I wanted to share a little bit about the actual process of how donor milk and milk banking works and have a brief summary of the overall process because it can take, just to point out, several weeks from start to finish from the time we get milk to our doors and out of it later on. So it all starts with moms having extra milk and being interested in donating it. So once they have their own baby's needs covered, we've had moms call, and they usually find us, by way of the internet, and contact the milk bank. These moms will go through an extensive screening process, and it's similar to the screening and interview process that for people who are donating blood. Plus, it's, as Dr. Kim mentioned, these donors are vetted, and there's additional questions that are asked pertaining to health and lifestyle choices, and then detailed questions about medications, herbs, and supplements that they're taking. Once they've completed the screening and completed an application, there's a blood test for 5 communicable diseases that the donor is asked to have, and those tests for HIV, HTLV, hepatitis B and C, and syphilis. And these are paid for by the milk bank. So if the donor passes the screening and the blood test and she is approved to be a milk donor, the arrangements are made then for her to drop off her milk at a depot. So once we have what are called depots, and those are community-based collection sites around the state. We currently have 24 depots around the state, and as you can see here, they come in all different shapes and sizes and forms, are located usually in hospitals or clinics and some public health buildings where approved donors' milk can be dropped off. And we're continuing to open depots to increase access to our collection sites, to make it easier for our donors to get their milk to us. And you can see here, this is Sarah from Pipestone. She's not only the donor coordinator out there, she's also one of the first donors, and that is her milk sitting on the freezer there. So it has worked out really well to have coordinators who are also involved at the sites where they collect milk. Then it's a matter of getting the milk from the freezers to us. And it can work in different ways, depending on where the donor is located and transportation. Some donors can drop it off directly at a depot. They can drop it off at the milk bank itself. We also have milk that's picked up by volunteers or staff by curbside type delivery. Milk can also be shipped by FedEx overnight if the donor is not in proximity to a place where we can do a transfer. And then we also have another option that we've been using a few times called Angel Flight Central. And as you can see, there's John there standing next to his plane that he has used. Angel Flight Central is a volunteer network of pilots who fly for humanitarian purposes, including getting our milk to the milk bank for us. And that milk that you see in front of him there in those coolers came from Wadena. And it's an opportunity for us to be able to get milk from our greater Minnesota depots such as Pipestone and Roseau. And I think one of our farthest donors lived in Devils Lake, South Dakota. So it's kind of fun to see these kinds of partnerships happening and allowing us to access our milk here at the milk bank. And then once it gets here, it goes into these chest freezers in the milk bank. We have some large chest freezers storing the milk with our blue bags in them, each bag having one donor's milk in it. And so some donors have several blue bags to donate. So just following the process of what happens here once it gets to the milk bank, it is sorted and then put into what we call deposits, which have about 50 ounces of individual bags inside them, and then it is pooled with 3 to 5 other donors to even out the variability in fat and protein content. Then it is mixed into large pots and then bottled and sealed, as you see here in our lab. Once that happens, then pasteurization follows. It's in a shaking water bath. That's using colder pasteurization at 62.5 degrees Celsius for 30 minutes. And then after that, it is cooled rapidly in an ice bath, as you see here, and then labeled and then frozen in a walk-in freezer. We offer 3 different kinds, or 3 different types, bottles at least, of milk. The smaller bottle is preterm milk, and it comes in 50 ml aliquots, and then 3 ounce and 4 ounce of term milk. It is also tested by an outside lab for bacterial growth, and if it's negative for growth, then it can be approved to dispense. So it ends up going to hospital NICUs, special care nurseries, and then well baby units as well. Well baby units will use it as a bridge, usually until mom's milk supply comes in. The shipping that we do is in insulated coolers and can be done using same-day delivery by local couriers in the metro area or by FedEx Priority overnight for a next-day delivery outside of the metro area. We're trying to move towards being more environmentally friendly and move away from using styrofoam boxes and things, and began using some reusable coolers for some of our larger hospitals that order a lot of milk, and then also recyclable cooler liners like the one on the lower right here. I just wanted to cover briefly before Jill begins to speak about the impact that COVID-19 has had on donor milk here at the milk bank. I think earlier in the pandemic, HIMBANA guidelines were much more strict due to an abundance of caution. And this included a long deferral time for milk donation before and after COVID symptoms or documented infection. Guidelines have evolved as evidence became available, showing that breast milk has not been found to be a source of COVID infection, and no reported transmission to the baby from the mother has been found through breast milk itself. And as more evidence became, more research was done, Holder pasteurization has been found to inactivate the SARS-CoV-2 virus in pasteurized donor human milk. And I just put 2 of the studies that were published this summer, and these are linked to the open access articles, so you can get those if you get the slides. So since the beginning of the pandemic, donors have been screened for COVID-19. And there is a deferral period of 14 days after symptoms or quarantine has ended. And this is because we know that pasteurization takes care of the virus. These measures are really to protect the staff at the milk bank from exposure. And so finally, the last thing about COVID is that we have some other changes that have occurred that are related to making sure that we're able to operate because we have to be on site to process the milk. We're limited at the milk. We've limited access to the milk bank by any visitors. We stopped giving tours. We screen staff daily, things like that. And then for a while, our depot openings were put on hold. And then as things started opening again, as you can see here, when University of Minnesota's Masonic Children's Hospital became a depot for the milk bank this summer, they did a post about it, about the opening. So milk is transported from the depots using curbside drop-off, which is a way to protect both the donor and the milk bank staff. So, and even before the pandemic, many of our depots were doing this already, although without the masks. And to make it easier for donors to manage the transfer. As you can see in that picture, this donor is, there are several bags, I think at least 4 or 5 bags, blue bags that she's filling, and she had a lot of milk, and each one of those blue bags, when it's full, can weigh about 20 to 25 pounds. So having the curbside transfers, it just makes it easier to avoid having to schlep very heavy bags throughout hospital corridors and through parking ramps and things like that. So it's something that was happening mostly anyway. I think the last thing I'll mention before I move on about COVID is that there was an initial concern from Havana that donations would drop during this time. And we have found that the exact opposite has occurred. Our theory is that, we've had donors just calling our milk bank for just the phone calls were ringing off the hook. And our theory is that the stay-at-home order has resulted in many more moms being at home with their babies and not needing the milk that was pumped for daycare. So we were very fortunate to have such generous donors who have had a lot of extra milk and are willing to go through the screening and donation process and getting their milk to us. Like many others, we've had our challenges with COVID, but we have not had issues with milk supply here in Minnesota. So with that, I will move on and introduce Jill.
Linda, can I ask you a quick question first before we move to Jill? There's a question in the question and answer. This is Linda Kopecky. About the photos in your presentation, are all the process photos from the milk bank, or are they from
Yes.
So from your milk bank. Okay. Great. Okay, so now we'll pass along to Jill.
Hello. I don't know if people can see me, but okay. So I'm Jill Lindquist, and I'm the board chair of the Minnesota Milk Bank for Babies, and also have worked in lactation for 25 years. So I'm going to talk about the safe and efficient use of donor human milk in a hospital setting. So basically, there are 2 methods for hospital use that we want to make sure that we use every drop. So I will review both of those methods with you, and you can see which one kind of will fit into your system a little better. So it's very important to know that multiple babies can safely take milk from the same bottle, and that's what we want to discuss, and showing you the different types. But as we've been, known this year, that it all begins with good hand washing and good aseptic technique, and that's the very beginning. And that fine bottles of human donor milk is really the same process from baby to baby. So you want to have your preparation station. So some hospitals might have it where you have one central location, and you have, if you're large enough, you might have one person, one technician, one nurse that's drawing up all the milk for all the babies. However, most of us are going to have one central location. So you want to make sure that this location, which contains the bottle warmer, the refrigerator, the freezer, all your supplies, a sink close by, Everything is washed down, and we want to put on gloves, and then you are going to go and proceed to thaw that milk if it hasn't been already. And I'll talk a little more about the thawing machines later. So your first method is going to use a sterile bottle or a VoluFeed, either of those that is available at your hospital, and on the left. And on the right, you can use a sterile syringe. Now the two on the right-hand side of the syringe screen, those are the ENFit, and that's what many hospitals use. And if you can see rare at the bottom of that, that it comes with its own sterile stopper, and that's why it's used by many of the hospitals. However, you don't have to have that system. You can use, on the left side of there is just a regular sterile syringe that you can use to draw up. But if you don't have the ENFit stopper, then you need to just use a regular rubber stopper that comes with any of those syringes as well. All right, so your method one, you're either, if you're using your VoluFeed, you're just gonna pour the volume of milk that you need for that particular feeding into your bottle or your VoluFeed, and you're gonna draw up with a syringe. So you're using a sterile syringe, and you're keeping the tip of that sterile, of that syringe, and putting it right directly into the bottle and drawing up whatever amount that you need for that baby's feeding. And then you're going to be warming it up after that, but you're going to place a cover on it, or if you're using the syringe, you're going to use that rubber stopper, or you're going to use that ENFit cap that comes with it. And then it's ready, whether you're bottle feeding, syringe feeding, finger feeding, gavage, SNS, Hazelbaker, any of those types of feedings, either of these methods are going to work well. And then that bottle, that same bottle that you've used, is going to be recapped and placed back in the refrigerator, and it's ready for the next baby. All right, so warming them up, you're going to want to make sure that you have a commercial grade or hospital grade bottle warming system. So there are a couple different kinds. The one that you see in the picture here happens to be a Medela, and that's a warm air circulating. There is also a warm bath. I believe it's Amita. They use and they call it the Penguin. And that's, again, a commercial grade, hospital grade warming system. So either one of those are going to be fine. You'll just see what's going to work better for your facility. In this Medela warm air one, you can see that there is there's a liner that goes in the middle where you're placing the bottle and or the syringe, and that gets replaced every 24 hours per Medela's protocol. But you can put it right, if you have your VoluFeeder bottle, you can put it right into the middle of the warming bath, or if you have a smaller amount or have a syringe, you can use it where it's demonstrated at the bottom. They've got that hole that works really well for a syringe if you're doing smaller volumes. And your second method, again, both of these methods have been used by hospitals, either method, for years and years and years. So again, this one happens to be a Medela product, but it's an ENFit. And what that is it's a transfer lid. So it has a standard threading that comes with the Minnesota Milk Bank for Babies. Milk also has a standard threading, and the VoluFeed is a standard threading, all of that. And so you're actually going to just take off the lid that comes with the milk bank, the milk from the milk bank, and discard that, and then put this on. And there's just one lid per bottle, and it's recommended that that just stays with that bottle until you've used everything, you've used it all. And then, as you can see, you're still taking your sterile syringe, you're just opening it up. It's just like a vial. You're just drawing up the amount that you need, and then you're replacing the cap onto the donor milk, and you're placing the cap onto your syringe, and there you have. Either of those methods are going to be used very widely around the cities. And so what really the main thing is that we're not wasting any of this milk. You saw that whole trafficking from Dr. Kim this morning, and the whole process that Linda was talking about. And it's just it's a lot of work from the moms and for the milk bank, and that gets it to your hospital. There's many, many steps that happen. And we want to be good stewards of all of this generosity of our moms that are giving their milk. So either method is going to be efficient and effective, and it's going to save as the human milk. So it's going to save any pasteurized human milk, that we're not being wasteful of that. And that's going to be good stewards as hospitals of the resources that you have for your babies. Because that is our bottom line, is to help our babies.
Thank you.
Yeah.
We can move along to Dr. Kim a little bit earlier than we had planned. I know he's here. And then we'll take, I just want to remind all of the attendees to please start putting your questions for all of these panelists in the question and answer section. And then when Dr. Kim is finished, we'll entertain questions for all of these panelists on all the topics. Thank you.
Great. So let me give you a little bit of detail with regards to the program that we developed a number of years ago that really aimed at supporting premature infant nutrition centered around mother's milk. It all started really with the foundation of what is in quality care, which is really something that's, I think, exploded in the last 15 years within neonatology. I think we're quite far ahead of many groups in terms of how we incorporate quality improvement. And foundational to quality improvement is when you see large variation in practice, whether it's often associated with areas where there's not as much evidence, and so that people tend to spray in terms of how they perform. And being able to narrow the field, narrow the approach in an area allows us to be able to deliver more consistent care, and in our case specifically in terms of nutrients and goals for growth. The resistance that we face in all the things we do when we try to standardize is people resist the idea of protocolized medicine, resist the idea of someone else controlling. And something we continue to work on in the field is trying to change the individual provider and caregiver from decisions that are made because of our own paradigm versus what is best for the team. And standardized care is one of those areas. So why is it important to develop an approach? I've kind of alluded to before that the premature infant has tremendous challenges in growth, and in particular in the past, it was quite remarkable how many of our babies, virtually 100% of our very low birth weight infants, were failing to thrive. In other words, they fell many percentiles, many standard deviations below, and they all graduated out very, very small, losing weight and losing really cognitive potential overall. So we've come a long way, but the perspective that I shared earlier is that we got stuck with human milk alone because it wasn't able to give the sort of the higher level of requirements of the preterm infant. And so we had a period where we depended on preterm formula, and then now really moved into the mother's milk or the human milk era. So when we look at standardization around human milk, we clearly can look towards a wonderful model called the Baby Friendly, which everyone should be familiar with, and the impact that it's had in standardizing an approach, in implementing routine education and practice for getting moms and babies together and to encourage breastfeeding. And the derivatives of the outcomes of that have been really tremendous. But we really didn't have anything in the preterm area as it related to a similar thing in terms of not so much breastfeeding, but more an emphasis on human milk and so forth. So we came up with the concept of trying to standardize an approach in a very similar way that Baby Friendly did, so that we could really create a focused center of excellence around nutrition. But really beyond that, it's really focusing on human milk as a center, with the aim of trying to improve nutritional and long-term health outcomes for the preterm infant. So we've had a similar kind of 10 steps and modified it over time. And so this is our current iteration. It really drives home a couple of things. One of the biggest things that we saw, which is a barrier, was trying to have all the stakeholders at the table. So having nutrition-centered people and lactation-centered people talking, because many places we saw, and even within our own center, that you'd have different silos working on objectives, whether it's to help mom make milk and to grow babies on the other side. So merging that into a common team was one of the most important things that we did with the SPIN program. And then, as you can see, and I'll walk through the 10 steps briefly, we try to get objectives to improve nutrition, improve mother's milk delivery, and really kind of help standardize some of the trajectories. And none of a complex problem can be solved without a major team. So identifying stakeholders, all the players within your unit that can feed into the development of the program was really, really essential, and including having administrative hospital level support, that this is something that's valued. And I'll tell you where, you know, they initially made some strong commitments to making the program happen. So like Baby Friendly, having a strategy where education and policy are built right in and hardwired in is really, really important. So sort of stating that outright and having your team develop all the documentation of everything that you want to standardize, you want to do as a group with consensus. And that takes time. That takes a fair amount of effort to get those details and to go back and forth. And it, like any other quality improvement, it should be iterative. And I think that was something that we went through many, many cycles of this. And I'll highlight the infant-driven feeding. We did many things at once and realized we flooded the nurses with too many protocols and too much strategy. So we actually left that one particular thing, the cue-based infant-driven feeding, till the end, and it took probably almost, I'd say, 10 years before we got back to it. The second step that we put in after the fact was this idea of family-centeredness. And that has certainly been a principle within the NICU, but I think it's really important when we look at how do we get moms and babies really connected, being able to not only just provide education, but recognizing that the mom is part of the complex care of their child, and to recognize her parenting and the family's parenting early on, and really to make making milk and recognizing growth as an objective, as a common element. Really, really important to put that in the forefront. So I talked a lot about how to build that 100% human milk base. I think making that emphasis and the driver of that being one example, really, probably the most obvious example is what I discussed around necrotizing enterocolitis, and to have this perspective of trying to improve the balance of how much mother's milk versus how much bovine-based formula or even bovine-based products, so intact protein being something negative. And that the humanization of the diet for preterm babies has really marched along quite nicely over time. I'd say we still don't have a complete answer for those babies that are now on the newer liquid fortifiers that are fortifying human milk, because there's not enough data to suggest that it is as good in terms of reducing NEC. I'd say probably not, but we don't have that data. And then when we're looking at growth, as well as prevention of NEC in the NICU, having standardized enteral feeding process. And I really like this diagram where you look at the entire journey, the nutritional journey of preterm babies, from the beginning where they're on IV parenteral nutrition, transition to enteral feeding, advance, and then move along in growing, and then finally going home. So I think we're still really only at the beginning, in my mind, of standardizing approach. Most places have done a great job early on in standardizing parenteral and enteral nutrition, and not as much in the bulk of stay in a baby's journey in the unit, where they're on regular feeds for a long time, then they start to have oral feeding progression, and then establishing breastfeeding really at the terminal end, and then nutritional discharge. So really, I'm trying to have standardized approach to how do we prevent babies from failing. As I mentioned, we're doing better. It's not 100% of our babies are falling off the curve, but being able to have and this I think is where electronic medical records has helped us a lot. Used to be we had paper charts and we had to put dots on a piece of paper. Very hard to really standardize an approach and be consistent. Much better now, but I'd say it's still a challenge to be able to grow babies so that they don't fail by the time they get out. So being able to have very clear standardized ways of measuring and responding to the poor growth is important. And not all babies are made the same. So we have a lot of complex kids who have not only born small, but they're born growth restricted, or they have unique challenges. They're only donor human milk fed, as I mentioned that before, that could be a potential risk for their nutritional growth. And then we have kids like those that have chronic lung disease or BPD, huge energy expenditure with their tachypnea, very difficult to make them grow. And then we've been surviving a lot of kids with intestinal failure or dysfunction, and they are unique populations for growth. Having in place really good approaches to mother's milk production, and you've kind of heard a little bit about strategies. I think having a comprehensive approach from the get-go, having pumps available to moms, having them to be able to go home with pump equipment, having a seamless process of milk moving from wherever they pump to getting to the hospital, and having accounting of the milk when it's in the hospital. This is a large, complex model of how to make that happen. And the one aspect that I alluded to before is the whole area around milk quality and safety. So we are more responsible for the milk, and so we need to put in standardized process and protocols so that we can actually deal with all the various steps of the handling. So what does that mean? It means that every step probably requires some level of detailing of how do we do this? How does milk move from one container to the next? How does it get stored? What's the temperature life cycle of that milk sample throughout? And how do we get it so that you don't have mix-ups? So a lot of places, including ours, have gone to electronic scanning systems to make sure that milk is reliable going from mom to baby, their own baby. But I'd have to say that these systems are not perfect, and even with a really good labeling and scanning system, you can still end up with error of giving milk to the wrong baby. And then I mentioned earlier that when we really inaugurated our program, we got administrative support for dedicated milk technician, a diet tech that could really do the mixing and the preparation for the whole unit. So rather than have 150 nurses learn how to do the mixing, you had a dedicated crew that could do it and do it in a consistent space. But space is a premium, I have to say. So we didn't have a dedicated space for years until we really moved to a new building, and then had space that was much more professional and closed, and airflow being really good and having the right equipment. So sometimes that can be challenging. And then getting towards that goal, the holy grail of being able to breastfeed a preterm baby on moms, really difficult. But one of the early things that was very difficult for many units is to be able to establish some bonding, skin-to-skin care where mom and baby, even in the setting of a baby who's got respiratory symptoms, really essential to get that initial physical bonding established. And then over time to have non-nutritive approaches so that baby is actually learning to suckle at the mom's breast, and then when milk is starting to be handled at the mouth, to be able to transition that baby so that they have some degree of breastfeeding at discharge. And I say we have a long way to go, because some countries have moms really staying in hospital for a lot longer, and they're able to establish full breastfeeding for preterm babies. But these are countries that have much longer maternity leave and much better social policies. So it's rare for us to have a preterm baby go home fully breastfeeding on their mothers, but it really is one of those goals to at least have some establishment. And then I mentioned that one challenge of getting oral feeding progression, and it took us a while to develop an algorithm that we were happy with, but also an algorithm that could be digestible by both the nursing staff and the parents in understanding. So we had two different versions of this, one that's easy to read from the parent side and one that we used as our algorithm. And we've been very successful in getting babies transitioned to oral feeds with this. So much more standardized practice, and we're able to, we have data that hasn't come out yet, but similar to some of the published data on cue-based feeding, where having structure, having an algorithm gets you to the finish line faster. And then the final step is really one of the hardest steps, and that is really sending off babies on with a comprehensive nutritional discharge plan. And the way I look at it is that we transition babies from a very high level of care and then send them off to a minimal sort of attention care, relatively speaking, where the pediatrician that receives this baby often has to deal with so many different complexities, long problem lists, and challenges in being able to know what the next step is, particularly when it comes to nutrition. So it's a huge follow-up and a real recipe for disaster. So having structure in this area where we provide information for the primary doctor, how to supplement, how long to supplement, and what are the growth objectives of that baby, and then of course breastfeeding, being able to provide the right resources for moms to be able to provide, get education, and sort of that period where she's escalating her ability to breastfeed, there needs to be some way to structure that. And I mentioned this loosely in terms of one strategy that we introduced into the country was to work with an in-hospital 30-cal formula and use that in the outpatient setting to support preterm breastfeeding, but also to get that extra nutritional support for babies. And this has been, hugely successful, and we've had a number of opportunities where states have been able to cover it under both Medicaid and their private insurance. And so if I look at the roadmap of how much mother's milk is starting to really populate the spectrum, we really are seeing not only the very preterm babies being standard, where they get oral colostrum care, which I haven't talked much about, but that's really become a increasing standard, along with mother's milk or donor milk until a certain age, and most have accepted sort of 34 weeks as the target. We're seeing more use of mother's milk in the moderate preterm and even the late preterm. If anything, the term infant has jumped the gun a little bit. A number of hospitals have used donor milk to supplement term babies in order to keep the statistics of having human diet for those babies, since it's a benchmark that the JCAHO follows, so as a hospital standard. So our program has been recognized as one of the best practices that can be used by other people, and really have been happy to see that over a number of years we've had very little significant surgical neck, in particular, in addition to overall neck. And for whatever reason, we've also seen, and may or may not be related to this, but a reduction in our spontaneous perforations. And our growth trajectories has been very stable over time. And I think we've introduced a number of different concepts that other people have adopted, but I think there's still lots more to do. So hopefully that's giving you a overview approach of how and why the concept of having a standardized approach to preterm infant nutrition as it revolves around human milk is really essential to standardize our practice such that we deliver the best care. And I'll end there and answer questions at the panel.
Thank you so much. This is Linda Kopecky again, and I'm going to invite Jill Lindquist and Linda Deck to start their cameras and open up their mics. I have several questions already for different panelists, but I may pose it to one panelist, but I would love the other panelists to feel free to chime in with their perspective. So the first question that we have, and I think this is probably directed to Jill and Linda, is do you have written resources that we can include with our patient education for moms that want to donate? Also a list of milk depots around the state.
Yeah, I can answer that. Yes, we do actually go to our website. We have a tab that provides a list of all of our depots under the depot tab. And there is a map. It's a little bit outdated. We are kind of in the process of, as well as updating our logo, having done that, to update our website format. But yeah, the current list of depots is on that website. And then, yes, we do have written materials that we can share. And again, they're in the process of being updated because of a graphics update. We have some current ones, though, that we can share for now, and then have that available for families that are interested.
Thank you. And Linda, would you put the URL for the milk bank in the chat section for everybody, please? Second question, Dr. Kim. Could you speak to supporting all families to receive the support they need to provide mother's own milk to their babies, particularly families with socioeconomic language barriers? Many of these families may be of higher risk for preterm birth, but have very little support post-birth. For example, needing to return to work pretty quickly, transportation issues, or other children at home.
Yeah, I think we need to provide broad-based support and recognize that there's great disparity in this area. We did our best in California to provide all our materials and to give bedside support in Spanish or English, but that didn't address other communities that were in need. If anything, with COVID and the recent pandemic, the disparity actually has gotten a lot worse. So, and we've seen that, and we've kind of been looking at it in our own community here, where in Cincinnati, where we saw a lot more infection in our Latinx community, and kind of it just came out as a surge, and we need to recognize that. So I do think that we need to be able to find within our own systems ways to address the broader community that is at risk, and that's unique to each of our communities, but paying attention to the fact that there are these hindrances. Big picture, just because I grew up in Canada, having such a brief maternity leave set up in the U.S. is really challenging. I think that's where we could have great traction if we had better social coverage for those moms, so that they could spend a longer time and without feeling economic burden.
Here. Thank you very much. I agree with the extended parental leave, absolutely. Another question, probably for Jill and Linda. How important is it to thaw the entire bottle before using? Would the product be different if taking thawed amount off the top versus the whole product thawed and mixed prior to drying out donor milk? In a smaller facility where one bottle is used per baby, can this bottle be extended past 24 hours after opening, if only a small amount is thawed at a time?
Yeah, well, it is going to make a difference in your in the composition, unless it is thawed or nearly thawed. Sometimes there's some slush in there, but because you do want to have mixing, there's separation that goes on even when you receive it and you thaw it. So you need to be mixing that. But maybe where you say where one bottle is used per baby, maybe now you are going to be able to use all of that if you can use multiple. If you use one of the methods so that you can use multiple babies per bottle, then you're not having to throw away any of the milk.
Yeah, and the guidance that about the 24 hours, the guidance that we were given from Humana says milk thawed, pasteurized donor human milk that is thawed can be used up to 48 hours after it is completely thawed.
And that's what is used in most hospitals, is the 48-hour mark. Correct.
Thanks. I have a couple short questions for Dr. Kim. One is amazing statistics on NEC. What is the number of babies approximately that you're seeing in your unit annually?
So prior to this, we were averaging what other people had averaged, around between 5 and 7% total NEC, and we had gotten that down to the sort of the 2%, 1 to 2% range. But probably more importantly was the spread in the incidence of surgical NEC. So, because sometimes the medical NEC is kind of a question mark in terms of people making a judgment. If they saw an X-ray and the X-ray showed a little bit of possible pneumatosis, and they hold the feeds and they call the baby NEC. But the babies that had true surgical NEC, we had periods of 2 or 3 years where we would not see surgical NEC. So for me, that was the most gratifying because those are the kids who actually lose bowel and have tremendous amount of inflammation and have consequences for brain development and so forth. So that's probably been the biggest impact. What's going to happen next is what was emerging is a lot of people starting to use probiotics, up to maybe 20% of NICUs. And so the added effect of having different kinds of probiotics on top of mother's milk that has a little bit of probiotics and prebiotics is going to be really interesting to see, because there's definitely data to suggest that will enhance reduction of NEC and all-cause mortality in a number of the preterm babies. So that's going to be potentially even better health outcomes for our babies.
And another quick question for you about the administrative support for a dedicated milk technician in the NICU. So how'd you do it?
I don't know how we got lucky with that. One of the board members, when we presented, well, one thing at that time, my division chief supported the concept. So first thing was we had buy-in from my immediate leader. Second thing was when we presented to the board of the hospital, we made a compelling case, and one of the board members happened to have a preterm baby in the unit, so maybe there was a bit of softening, but they recognized that some of these structural elements were important, so they provided. At that time, we didn't have a dedicated lactation coordinator for the unit, so we got a dedicated LC and a dedicated milk technician, and that really helped jumpstart our ability to provide service and to get the program running. And then my partner, Lisa Stellweg, and we actually carved out about 9 months of her time where she could just dedicate to helping construct a lot of the organizational elements of the program. So there was some institutional buy-in to say that it'll take a lot longer to build unless you dedicate some time up front.
Thanks. A question probably for Linda and Jill. Our nurses have had to take on the task of milk barcode scanning, and it is painstakingly time consuming as milk has to be scanned multiple times before it reaches the baby. Unfortunately, this just makes supporting breastfeeding in the NICU take on one more time challenge, taking precious time away from the other breastfeeding support nurse-mother interactions. Have you encountered this?
At a couple of facilities that I worked at, they were talking about the barcoding, and then it always got bumped to something else and something else. So I've never been in a facility where they actually have the barcoding, but now I'm thinking that's a good thing. So what they do is they just chart an Epic, or whatever electronic medical records, the expiration date, the batch number, the lot number, everything is just charted into there that would be obviously bar scanned. But I didn't know that was, that you had to scan that multiple times. So I haven't personally worked with that. So yeah, that's too bad.
I could probably comment on that briefly. We had gone through the growing pains of one of the first iterations. It was a good system, but we just built it too onerous for the nurses. So they had to go through so many different steps, and then it would block them if they didn't put the right data in. And so they'd be sitting there trying to feed their baby, but they had to get it into the order, into the medical record system. So it has gotten a lot better since then. So I would encourage a lot of them will help customize. The goal is to keep it as simple as possible so that you have buy-in and compliance by nursing. We made a lot of mistakes early on and almost killed the whole program because it was so painful. So lesson learned.
Thank you, all of you. We have a few more questions. One is, do you have recommended summary text? So translation could be easy and inexpensive, and URLs that can be linked to Epic after visit summaries, AVS. Is anyone doing this now? Is it effective in that way? Or do we know if it's effective? Mixed results on building things into AVS. Also, is the Minnesota Milk Bank site built on a platform that can be Google translated or forms translated, or is non-English intake done via language line support? Anybody?
Well, so maybe somebody, Jill or Dr. Kim, could answer the first part of that question, and I could cover the second part.
Go ahead.
There you go.
Sure, cover the first part. Feel free to cover the second part, Linda, first.
And the question just disappeared. Can it come back?
Yeah, it did
Oh.
disappear.
Maybe I could tackle the first question while you're pulling
Go
that.
for it, yes.
So if I heard it correctly, it's about trying to connect the hospital records and the visit summary so that there's some handover and that connected space. Is that
Right.
what I'm reading
Yes.
correctly? So I think there's huge opportunity now that we've got electronic systems and we've got ability to reach out to primary care people, but even to parents through MyChart, that's in an Epic system, but other equivalent ways for us to be able to do really good handover of what we were thinking in the NICU. You know, what did we think of a baby's growth? What do we think of a baby's nutritional plan? Put that in so it's really baked into a discharge system. When we started, we had everything on our own forms. We created a nutritional discharge form, wrote it out, typed it out, and then we had handwritten, summaries of what we thought the plan was. Nowadays, you can build all this into Epic. So the dietitian fills in information, the lactation coordinator puts in their information, the physician puts in their information, and that package then gets handed off to the pediatrician or the receiving doctor, and they get a really nice compendium of what the nutritional discharge plan was at the time of departure.
Thank you. Linda, do you see the question about platform that can be Google translated?
Yeah, and actually I don't actually know the answer to that
Okay.
question.
The question
Not yet.
is the Milk Bank site built on a platform that can be Google translated? Are forms translated, or is non-English intake done via language line support?
So at this point, I don't actually know if ours is Google translated, has that ability to do that, but I will check into it. And our forms translated, at this point, they aren't, but we are moving towards a different, more of an electronic system. One of the things that we do encourage that, there's a conversation with a donor coordinator here if there's interest in donating milk, and we do now have somebody who does speak Spanish. But for now, we have not had a lot of donors calling who speak another language, although it is something that we can offer and we look into in terms of language line access here in Minnesota. So it's something that we're considering and considering doing. But at this point, most of our forms thus far are in English, and we are looking to translate into Spanish at least.
Thank you. Next question. I think this is probably directed to Dr. Kim, but it's open to anybody. Are you finding changes in the NICU with COVID-19? I'm finding mothers are choosing to bottle feed, express milk, or formula versus breastfeeding to get their babies home sooner.
All of the above, yes. It's been, but I don't know if we have data that they ultimately lose ground in terms of breastfeeding when they go home. There are a number of efforts trying to track West Coast, East Coast, that's trying to track some of the data. So we probably will know what at least the first surge effect. Now we're heading into a next surge. We'll have to see how that impacts since we're a little calmer this time around. But yes, it's affected significantly when we initially had mom and baby separation, like major separation, and then we got better with it. Most places had sort of shared discussion and having mom and baby in the same room with a certain distance.
Next question, please discuss insurance or medical assistance coverage of donor milk and plans by state and nationally, and question about plan for the Minnesota Milk Bank expansion and growth in the future. So insurance coverage, medical assistance coverage, and then particularly the Milk Bank, what are your plans?
Yeah, so this is something that it is a huge issue, and in terms of addressing equity and access to donor milk, and I probably hear about it almost daily, because we are at $4.50 an ounce and $18 for a 4-ounce bottle. And there are very few people who can afford that. And where MA, in our state, MA and insurers do not cover this as a product yet. I think there's now up to 11 other states that have legislation and coverage of some sorts for pasteurized donor human milk, and it goes state by state, unfortunately. Himbana has, I'm on an advocacy subcommittee with Himbana to look at ways we can expand coverage for this to other states. It does take time and energy to do this kind of work. Having hospitals assist with this is really important because they want to hear from you and why it's an issue, not just for hospitals can't continue to eat this cost without being reimbursed for it. I think we've already heard that anything that's not reimbursed is usually something that is at least cost neutral, something that tends to be cut. Or limited. And I've had a lot of families who have asked the milk bank or approached the milk bank to provide donor milk for babies who are still in the hospital, and in some cases still in the NICU. So it is an issue that I would like to see move forward, and hopefully in the coming year we can start putting together some subcommittees and working towards coverage for this. And I don't know, Dr. Kim, if you can share a little bit about what happens in your states that you've been in coverage for this.
Yeah, so California has some measures to cover a portion. I wouldn't say it's 100% that the hospitals get it covered, but it does have some measures. In Ohio, we don't have that in place, but there is an activity through the American Academy of Pediatrics that developed a toolkit on the advocacy of really lobbying for this. So I wonder if there might be an opportunity for that committee and that toolkit. I'm a little bit behind in trying to get that activated for Ohio, but Georgia's the other state that's trying to do this right now with that toolkit. But I wonder if Himbana or your bank and the AAP effort can come together and just really look at the approach or the strategy now that, well, it's not completely over yet, but however the legislature gets settled after the election, it'll then let us know who we lobby towards.
Yeah, and it is something that I think will involve obviously DHS, but the Minnesota Hospital Association and other, the local chapters as well, to garner support for it, for anything to happen at the local level. And I know Himbana is interested in seeing something happen federally, because for each state to have to do this is just, it's not given that what we know now about the research and everything, a national effort makes more sense. But given how things are currently going, as of now, it is a state-by-state effort. So stay tuned. There will be more information coming out about this, and to think about at your facilities, who could help with this, who could help join a subcommittee, help be a champion. I can tell you Chip Martin's on my list of people to approach, because that's the kind of those champions that we'll need to take this forward and to see that something actually happens.
Oh, thank you. I have a question specifically, I believe, for Dr. Kim. So with your NICU, are your neonatal dietitians expected to acquire IBCLC certification?
I don't think so, but we do have a lot of IBCLC trained dietitians, nurses, and faculty. I was surprised. One of the things I was attracted to Cincinnati was that there were a lot of neonatologists and pediatricians that have IBCLC training.
Thank you. So we have another question. It's a little bit, little different vein. So it goes back to the discussion on natural inoculation occurring with newborns during vaginal birth. Any new data on how to achieve something closer to this post C-section?
So the original study was a very controlled pilot study that looked at C-sectioned babies, and they were able to place a gauze in mother's vaginal vault and then use that gauze to inoculate the baby after birth. So take that gauze that's been probably colonized with both vaginal and colonic flora, and then wipe it on that baby after a C-section delivery. And they showed that they could partially reconstitute the bacterial colonization in that baby's gut. And so the concept is a good one, but it's only under pilot data. There's broader studies that are underway now that will probably open the door, but it's not prime time for people to suddenly start coding babies at the time of C-section with whatever practice, because we don't have a good handle on, other colonizations that happen in moms that may have inadvertently have very bad bacteria growing. So it's not something we should generalize yet, but it's going to happen, I think, in one of two ways that I see. Either controlled, well-known cultured moms that that they have good flora, and then babies can get colonized in one way, shape, or form, or there's some other derivative product that is considered a good inoculum that one can use. It's a mix of good bacteria, and then we use that as a way to inoculate babies that are C-section delivered. So I suspect that one of those two might become popularized with data.
Excellent. Thank you so much. And we're almost done with the morning, but I want to finish up with Linda and Jill. Back to a previous question, what are the future plans of the milk bank?
Well, there's a lot going on for the milk bank. We have a lot of plans and a lot of dreams that we have, but Linda, why don't you go ahead and talk about that?
Yeah, just quickly, this is our first year, and we are, as I mentioned, building capacity, and that includes increasing production of the number of bottles and the type of milk that we produce. And that involves acquiring more equipment. Something like a SteriFeed pasteurizer would allow us to pasteurize in larger amounts and also in larger bottle sizes. We currently have the two sizes, 3 ounce and 4 ounce for term milk. And somebody asked a question about how much that milk is, and it is in a 4 ounce bottle, $4.50 per ounce. So it's $18 for a 4 ounce bottle. It's a little bit more for a 3 ounce bottle because, like with any other type of product, you buy a smaller quantity, you pay more for it. Our costs, we take actually a hit on producing the 3 ounce bottles, and we are trying to move away from that, which is part of the reason why in talking about safe and efficient use of donor milk and how to use all of the milk. When we hear about milk being one bottle of milk per baby, or to a baby's room, we really want to see the milk being used completely, but also safely and effectively. So by having the other amount that we produce is the 50 mils or the 1.7 ounce for preterm milk, and that will remain the same. That's not going to change because of that type of product. We're hoping to acquire a nutrition analyzer so we can have milk that is targeted with more different caloric offerings. We're going to keep adding more hospitals in Minnesota. And we kind of had a soft opening. We didn't kind of announce it to everyone because we knew we wouldn't be able to serve all the hospitals in the state yet. So we're kind of going step by step and reaching out to all the hospitals with the NICUs and special care nurseries, as well as other hospitals. At one point, the other plan was
Oh, Linda, your audio cut out.
Good.
Yeah, just the last sentence, I think.
Oh, just that we are working on like to get moving on getting donor human milk covered by MA and insurance.
Okay, and somebody asked to please define preterm milk.
Oh, preterm milk is donated from mothers who have delivered before 37 weeks, and it's for the first 4 weeks after delivery.
Okay.
And then after that, it becomes term milk.
Okay.
So it's very rare.
I want to say a huge thank you to our panelists, particularly Dr. Kim for the 2 presentations and just for piping in all the way from Ohio. to share your wisdom and experience with us. Thank you, Linda and Jill, for your local wisdom and experience. We're gonna finish out the morning and we're coming back tomorrow, but I want to thank everybody for attending, but also we need to remember that there are a whole group of people that are supporting us and allowing us to be on the Zoom webinar for 4 hours. If anybody is schooling children, the crisis schooling that we're doing in our homes, thank you children for being occupied and doing your job of going to school, and our family members and our amazing colleagues. Because this is a time where we're doing a lot of things alone, but we actually need each other more now during this time. So we'll adjourn until 8 a.m. tomorrow morning. I wonder if Dr. Heggie wants to say something, a final something.
Thank you, everyone. And I appreciate the comment in the chat inviting us to collaborate and to get out of our silos. So thinking about Minnesota Breastfeeding Coalition, the American Academy of Pediatrics, the Nurses Associations, the Minnesota Hospital Association, and Family Practice and OB, and us all coming together to support mothers and babies and families. And it's really an inspiration, as many of these summits have been, and lots of innovation comes out of these events. So thanks everyone for your ideas and questions, and we'll look forward to seeing you all tomorrow during our session. Thanks.
And just a reminder that it's a different Zoom link for tomorrow's session. So thank you everybody, and have a wonderful rest of the day.